Welcome everyone for the class on infectious diseases. The first thing what we'll be seeing is sepsis. What is sepsis? Most of us think that sepsis is a severe infection. It is grossly correct. Severe infection is sepsis. But what actually happens in sepsis? It's because of a severe infection, body starts responding, it starts producing a lot of antibodies. These antibodies not only go and kill the bacteria, which has been causing the severe infection, but starts kind of injuring your end organs, like your kidneys or any other end organs. That results in MODS. MODS stands for multiple organ dysfunction syndrome. So basically, sepsis is a severe infection resulting in your immune system producing antibodies which will start fighting against your own organs. For that reason, sepsis needs to be picked up at a very early stage. If you miss an sepsis at a later stage, it becomes very difficult to manage an sepsis. For that reason, a lot of importance is given in UK to pick up sepsis as soon as possible, especially in the emergency department at the presentation itself. Missing the sepsis in the emergency department, it might be catastrophic. The mortality rate and including the morbidity rate will increase drastically. For that reason, at least few questions will appear on sepsis. It might be just the management or the diagnosis. So in various forms, sepsis can be checked. At least few questions will definitely appear in the exam because sepsis, you will be seeing at least 2 to 3 cases in a shift in the UK. For that particular reason, sepsis is very important. Sepsis, as you can see, we will be starting from very basic definitions, for example, from systemic inflammatory response syndrome and going ahead to the latest research, what has been going on and what are the latest guidelines from the NICE. So you need to remember everything. Doesn't mean that the old guidelines you shouldn't be remembering. That will also be tested in the exam. So you need to be knowing in and out of the sepsis. First thing what we'll be seeing is we'll be seeing the criteria. There are 6 criteria. One is the temperature being on the higher side, that is 30, more than 38.3 or less than 36. Heart rate being more than 90. Respiratory rate being more than 20. WBC count being either less than 4,000 or more than 12,000. Any new altered mental status. That means any changes in the TCS which is new for the patient, even a drowsiness, even a slight alternate where the patient is confused is considered as one of the criteria. Blood glucose levels being more than 7.7 millimoles per liter in a patient who is non-diabetic. In diabetic, it might be in the normal range. It might be completely fine for him to have an 7.7 millimoles per liter. For that reason, you need to always see whether he is a non-diabetic and having sugar levels which are more than 7.7 millimoles per liter. If two of these are present, then we call it as an SIRS. What is SIRS? SIRS stands for Systemic Inflammatory Response Syndrome. 2 or more criteria should be present for this definition. Along with SIRS, if there is a source of infection or presumed to be a source of infection. For example, this systemic inflammatory response syndrome is because of a lung infection, this because of a cellulitis, or this because of a septic arthritis, this is because of a pyelonephritis. All this suggests that, okay, this is a sepsis. That is the definition of the sepsis according to the SIRS criteria. When do we call it as a severe sepsis? If there is an associated organ dysfunction. For example, associated acute kidney injury the patient is having, associated the patient is having an encephalopathy. All these are suggestive of an organ dysfunction along with the sepsis. Then we call it as a severe sepsis. When do we call it as a septic shock? We call it as a septic shock whenever there is a severe sepsis or in sepsis for that matter, and the patient is hypotensive. It's not just being hypertensive, it's a refractory hypotension. What is refractory hypotension? Refractory hypotension is anyone who has an systolic blood pressure less than 90, we know or we consider it the patient is being an hypotensive, that is the blood pressure being on the lower side. You give an fluid bolus. In spite of giving an fluid bolus, the patient's blood pressure remains less than 90, the systolic blood pressure. Then we call it as an refractory hypotension. So systolic blood pressure at presentation was less than 90. You give an fluid bolus, the blood pressure doesn't respond, it remains less than 90. Then you call it as a refractory hypotension. This is a definition of septic shock. When there is an evidence of 2 or more organs are failing, then we call it as MODS, which stands for multi-organ dysfunction syndrome. So you need to be aware of the definitions being tested previously, will be tested in your exams also. So you pick up an sepsis or septic patient or a septic shock patient or a severe sepsis, doesn't matter. Then you go ahead with the treatment. Treatment is the sepsis 6. What basically sepsis 6 stands for? 6 things needs to be done in an first hour. So in first hour, you're doing 6 things. What are the six things or what are expected of you? Start them on high flow oxygen within reservoir if the patient is hypoxic. So SpO2 values are less than 95%, then you start them on the oxygen. Blood cultures you will be collecting. Okay, at least two sets of blood cultures you will be collecting before you are giving the antibiotics. Remember that it's always advised to collect the blood cultures before you give the antibiotics. After that, you will be giving the antibiotics. According to the protocols, you are giving the antibiotics. Okay, it doesn't mean you have to give coamoxiclav or you have to give piperacillin tazobactam. It depends from protocol to protocols, from hospital to hospitals, depending on what local protocol says that antibiotic you will be giving. This is an empirical antibiotic what you are giving in the emergency department. We will not be having any culture reports available so that we can give specific antibiotics. Then we'll start with the IV fluids. The preferred IV fluids are the crystalloid fluids what we'll be giving. The two main important crystallized fluids we are aware of is NS and RL. The preferred one is RL. RL and Hartmann's is almost very much similar with only minute changes what are present. Check for the lactate values. Lactate values are basically available in the blood gas analysis. So you can get a venous blood gas analysis and you can check for the lactate values, which are very important. Start monitoring urine output. It's not absolutely necessary that you get an catheter done and you monitor the urine output. Without the catheter also, you just have to tell the patient that just collect the urine whenever you pass so that we can measure it. So you give a jar to collect the urine. In that way, you need to monitor the urine output on a regular basis. What happened next? Again, surviving sepsis, they met for the third international consensus and they came up with the definition. This is the definition what I was talking initially. Sepsis is a life-threatening condition that arises when the body's response to an infection induces its own tissues and organs. It's your own immune system which is fighting against your own organs. That's what happens in the sepsis. They said that instead of going with this criteria and all these definitions, let us use a simpler way to pick it up. It might be difficult for the nurses to pick it up in the triage area. There might be delay in giving the treatment because you're missed picking up in the triage area because triage is mainly handled by the nurses. So they kind of simplified this and came up with QSOFA, where Q stands for quick. SOFA stands for sepsis organ failure assessment. They said, look at three parameters. One is the blood pressure, another one is respiratory rate, another one is the mental status. If there is any alteration in the mental status, that means GCS being 14 or less than 14, give 1 point. Respiratory rate being equal to or more than 22, give 1 point. Blood pressure, that is systolic blood pressure, being equal to or less than 100, give another point. If they score 2 points, consider this as an sepsis and treat it like an sepsis, what they mentioned it. What did the NICE guidelines? NICE, this is surviving sepsis third consensus. This is mainly from the US. The NICE is mainly from the UK. They took up the studies, what they had done, and they came up with a criteria. They said that anyone who presents to the emergency department, divided, classified the history, respiratory rate, blood pressure, circulated, that is basically the heart rate, temperature, and the skin in three different categories. One is low risk category, another one is moderate to high risk category, another one is high risk category. So they want you to classify in this three. You can just remember it as a traffic light, like green, yellow, and red. They want you to classify into. Remember that the low risk criteria, everything is normal. So easy to remember. Everything is normal, easy to remember. The upper end or the upper end, what you are having will become an high risk of and moderate to high risk criteria. For example, here in the history, very simple to remember in the history is the patient comes, the relatives or the friends or any caregivers say that this patient has an altered mental status. But you feel he's answering all your questions. You cannot make it out. But the friends and colleagues or the relatives can make it out. This patient is having an altered sensorium. Here, you can subjectively make it out or objectively can make it out. This patient is having an altered sensorium. You ask few questions. He is not oriented. He's not oriented to time, place, or person. So you know that this patient has an altered mental status. Then it becomes a high risk criteria. If if the relatives or the friends or the patient relatives say that this patient has an altered sensorium and you feel he doesn't have it, then it becomes a moderate to high risk criteria. Here, the behavior is completely normal. In respiratory rate, if the respiratory rate is between 21 to 24 breaths per minute, 21 or 22, 23 or 24, then it is moderate to high risk criteria. If it is 25 or anything more than 25 is high risk. Here, you're just bothered about the systolic blood pressure. If the systolic blood pressure is between 91 to 100, it is moderate to high risk. If the systolic blood pressure is anything 90, even 90 or less than 90 is considered as an high risk. In heart rate, you're seeing this main parameter here, 91 to 130. Anyone more than or equal to, more than 130, you'll consider it as an high risk criteria. Temperature only comes in moderate to high risk where the patient is hypothermic. That means less than 36 degrees Celsius, what we are talking about here. Skin. In skin, if there is any signs and symptoms suggestive of an infection, like an reddish discoloration, erythema is present suggestive of an cellulitis, any discharge from the surgical site, any breakdown of the wounds are present, then it becomes moderate to high risk criteria. Other than that, any skin color changes are present. For example, cyanosis, or there is a rash which is a non-blanching, which is commonly seen in meningococcal infections, or an molten skin we are seeing. All this goes as an high risk criteria. Remember, only redness, erythema, which is suggestive of an infection, goes as an moderate to high risk, but non-blanching rashes, even though they are erythematous, goes as an high risk criteria. Cyanosis, mottled skin, all this goes as an high risk criteria. Keeping all this in mind, what we are doing it. You are suspecting a sepsis, you are done, and there is one, at least one. If there is at least one of this high risk criteria, what we have discussed, if present, how do we manage it? We send a set of investigations what will be set. We will be getting a blood gas so that we know what is the glucose and lactates can be measured easily from the blood gas. Collect for the blood cultures important so that we can give antibiotics after that. Collect blood for full blood count, CRP, urine electrolyte, creatinine, and clotting profile or clotting screening, you call it, which includes bleeding time and clotting time, INR, PT, APTT. Antibiotics within 1 hour of recognition of high risk criteria, you will be giving it. Antibiotics needs to be given within 1 hour of recognizing the high risk criteria. What about the fluids? If the lactate values are less than 2, you clinically decide at the bedside if the patient is dehydrated, you can give it. Otherwise, you can avoid giving the fluids. If the lactate is between 2 and 4, then definitely this patient will be requiring fluids, IV fluids, and you need to give it within an hour's time of recognizing sepsis or recognizing a high risk criteria. If the lactates are really on the higher side, that means it is more than 4, or the patient is hypertensive, having a systolic blood pressure of less than 90. Obviously, you will be giving the fluids. At the same point of time, you add up or you basically refer to the critical care. So this patient is really sick, might require an inotropic support. So please come down and have a look. It is important to involve the critical care as soon as possible. The main reason is you might have to get an central venous access done for this patient because inotropes acts best when you have an central line. For that reason, involving the critical care as soon as possible because the lactates are really high or the patient is hypertensive is important. What if you do not have any high risk criteria, but moderate to high risk criteria, there are 2 or more moderate to high risk criteria are present? Then the management depends on the lactate values or if there is any acute kidney injury. If the lactate values are more than 2 or any evidence of acute kidney injury is present, then you will be just managing how we are learned here. The same management, no changes. If the lactate values is less than 2 and there is no evidence of acute kidney injury, at that point of time, what we do is we repeatedly do a structural assessment every hourly and see whether this patient is deteriorating. Are there any moderate to high risk or high risk criteria which are starting to appear? Same thing holds good when you are having an one moderate to high risk criteria is present. If low risk criteria are present and there is not even one moderate to high risk criteria is present, then you need to rethink of your diagnosis. It might be something else which is going on in the patient. Coming to the IV fluids. IV fluids, plenty of questions do appear in the exam and plenty of confusion do exist in the exam. That's why I'm discussing this completely as a separate topic here regarding the IV fluids itself. IV fluids, usually we give in a normal person, we give in boluses around 500 to 1000 ml. Warm crystallite fluids, the preferred one most of the time is a ringer lactate, which is also known as Hartmann's. Very minor difference is there. Hartmann's is very expensive compared to the ringer lactate, but the ringer lactate is the preferred one what we will be giving. Is given over the 15 minutes in any patient who is in shock, that is basically hypertensive systolic blood pressure being less than 90, or you can even consider a mean arterial pressure less than 65. Okay, either values you can consider. Most of the time we end up just looking at the systolic blood pressure. You might have to give smaller fluid boluses as small as 250 ml for the patients who are known case of cardiac failure. Why? because they can easily go into fluid overload. Pulmonary edema can develop if you rapidly infuse the fluids. For that reason, you are giving a small boluses like 250 ml over 15 minutes and reassess and see the patient, how is he responding. After you give an fluid bolus, then what we do is we get an ultrasound scan done and see basically the inferior vena cava. What we are looking at the inferior vena cava. Mainly we are looking at inferior vena cava, whether it is collapsing or non-collapsing. Okay, this is important for us. If the inferior vena cava is collapsing, that means you can give more intravenous fluids. The venous system is not still at full, so you can infuse more fluids. That's what it indicates. If the inferior vena cava is non-collapsing, that means there is enough fluids in the intravascular space. Do not give more fluid. If you give more fluid, this patient might end up having an fluid overload stage. That is basically the patient might end up having an pulmonary edema. For that reason, do not give fluids if the IVC is not collapsing. The other parameter what we see is whether the IVC is distended or not. But again, IVC diameter changes with the respiration. Usually, if the IVC diameter is more than 2 centimeters, it is considered as a distended one. So more than 2 centimeter is considered as a distended one. If the patient doesn't improve with initial fluid balance and you see that still the IVC is collapsing, you can repeat the fluid challenge what we have explained here. So you keep on repeating the fluid challenges. If the signs and symptoms of cardiac failure appears at any point of time, okay, IVC is collapsing, but you feel that the patient is getting breathless because he's going into pulmonary edema, stop giving the fluids. Though I say here as decreased, no, you directly stop giving the fluids. That is the one what we follow practically. So in anyone who is septic shock, eventually we end up giving at least 20 ml per kg over 3 hours time. Okay, over 3 hours time, we at least, or it is recommended that you give at least 20 ml per kg over in 3 hours time. Okay, what is 20 ml per kg? Most of the time, you will not be having the weight given in your stem of the question. So how do we know how much fluid needs to be given? So you can consider any patient who has presented to the emergency department as 70 kgs is the approximate adult's weight what we are considering the Western population here, mainly the UK population. 70 kgs you can consider. So multiply by 2, it will be 1400 mils. So you can approximately remember that 1.5 liters I should be giving in 3 hours over the time in small boluses if the patient is in shock. That is what recommended unless and until the patient goes into fluid overload or the IVC is non-collapsible. Septic shock, ongoing requirement for the vasopressors. Then what you'll do? What do I mean by this sentence basically? Someone is a septic shock. You are given IV fluids, not responding to the IV fluids. You started on inotropes. Okay, still not responding. Then the recommendation is start on steroids. Okay, give steroids is what the recommendation is. So next one is when to consider giving inotropes. It is an important thing when to consider giving inotropes. When the IVC is non-collapsing. It is an important thing. When IVC is non-collapsing, it is basically suggestive that the intravascular volume is full. Do not give more fluid. At that point of time, to increase the blood pressure, you'll start on the inotropes. That is one criteria. The another criteria is if you are already given 30 ml per kg for fluid, that means how much? 70 kg is what we are considering, multiply by 3, that is 2.1 liters. So you can consider as if you are given 2 liters approximately of the fluid for the patient and still he has not improved. Unlikely the blood pressure will improve if you give more fluids. So consider giving inotropes even at that point of time. Those are the two indications what you need to remember when to start on the inotropes. At the same point of time, I'll put it across in many or multiple times. They keep asking about CVP, central venous pressure. Okay, central venous pressure, to measure it, you need to have a central line. Okay, central line is an invasive procedure and you need to have this central line in the IJV. Okay, if you have the central line, then you can measure the CVP. What do the latest guidelines say? Do not consider CVP as a sole parameter to check whether the patient is responding to the fluids or not. Okay, so basically it suggests that do not use CVP to check for the fluid responses. It is not a good indicator to check for the fluid responses. Previously, they used to do it. A decade back, they used to do it. Even a famous paper was published that is early early goal-directed therapy was there, where they used to use the CVP to treat the patients. Now the things have changed. They're no longer using the CVP. Remember this point. Another thing is it's an invasive procedure. So again, it's difficult to perform in the emergency department or difficult to do it immediately and get a value of an CVP in the emergency department. That's why we do not depend much on the CVP to really decide whether to start on inotropes or not. So it is not a good indicator about the CVP. Next thing, one more point, usually the confusion comes here is a patient who is stable. Stable in the sense, for me, the systolic blood pressure being more than 90. For this patient, okay, you have collected the blood samples, what you will be giving? Either I will be choosing the antibiotics to be given, or the patient I will be giving IV fluids. Choose antibiotics. Okay, because antibiotics is time sensitive. The sooner you give it, it reduces the both morbidity and mortality. Another circumstance I'll come up here is where the patient is unstable. Okay, unstable, where the systolic blood pressure is less than 90. He's unstable. At this point of time, whether I'll choose IV fluids or whether I'll choose antibiotics, at this point of time, choose IV fluids. You want to increase the blood pressure. The vital parameters are utmost importance because we always treat according to A, B, C, D, E. In C, circulation, the blood pressure comes in. Here, the blood pressure is really low. You need to intervene here itself. For that reason, giving IV fluids takes importance when the patient is unstable. You need to bring up the blood pressure. So your main important target acutely is to raise the blood pressure. Once you are given IV fluids or you started giving IV fluids, then through an other cannula, you can start giving an antibiotics once you collect the cultures. Okay, before giving antibiotics, always remember that you need to collect the blood cultures. Do not start the antibiotics without collecting the cultures. Fluids. We are continuing with the fluids. As I told you, Hartmann's is nothing but an RL. What is the advantage of RL and sodium chloride? What are the advantages and what are the disadvantages? These are the most commonly used crystallite fluids worldwide. Okay. The advantage here is both around 30% of it remains intravascular. Okay. It is not an colloid. So only 30% remains intravascular, but both of them remains approximately on the same value of 30% and 30%. Hartmann fluid, if you give in large boluses also, it will not cause hyperkalemic metabolic acidosis. But this is a risk which is involved in sodium chloride. When you give a normal saline to the patient, if you give it in a large volume, they might end up having hyperkalemic acidosis. Okay, in high volumes, when you give it, you see this, that is an important side effect, or that is an important complication what you need to keep in mind. Because most of the time, the septic patient will be in metabolic acidosis. You need to give large amount of fluids. You give large amount of fluids, the acidosis will not improve because it has gone into hyperkalemic acidosis. It does not, sodium chloride, the advantage is it doesn't contain potassium much. Okay, so you can give it in a renal failure patient or you can give it in any patient whom you are suspecting and high potassium values. If you're considering an high potassium values in patients, you usually tend to avoid an RL, but it is not an absolute contraindication. Okay, but for exam purpose, remember that you avoid giving you avoid giving RL in any patient when you consider this patient might be having an high potassium value. For example, someone who had an road traffic accident, you're thinking the patient might be having rhabdomyolysis. So potassium values will be on the higher side, so you may not be giving. So in those circumstances, you're not giving it. Someone who has a liver disease, it is not recommended because it is a ringal lactate. Okay, there is a slight amount of lactate is which is present. Okay, this is metabolized in the liver. It will get accumulated if there is certain liver disease. For example, alcoholic liver disease is present, chronic liver failure is present, or acute liver failure is present. In those conditions, you do not give RL. So remember, when you do not give RL, if you're considering this patient might be having high potassium values, or if you're considering this patient has any liver disease, do not give RL. If you're not giving RL at that point of time, you can choose normal saline. What happens in emergency departments in NHS? A patient in ambulance, the patient in the ambulance comes to directly to the triage area. In the triage area, what the nurse does? She collects all the vital parameters like respiratory rate, SpO2 values, systolic blood pressure, heart rate, GCS, temperature, and document this in the computer. They have a system in the computer. It goes in and gets a new score. New score stands for National Early Warning Score. So once they enter all these vital parameters, they get a score. It will alert you. According to the score, for example, news is 7 or above, or it is 5 or 6, it will give you an approximate value and likelihood of this patient having a sepsis. That's when the triage nurse will involve and doctor if the septic markers are hit, and the doctor will intervene and see whether treatment needs to be started. If yes, according to a checklist, usually we'll have a checklist. According to the checklist, we'll start the treatment and the prescription will be given by the doctor and the orders will be followed by the nurse. That's how it is carried out in NHS. Same thing holds good for the pediatric age group. Also, you have an pediatric early warning signs, ED emergency department pediatric early warning signs. It's an example here what I've given. Then you, according to that, you will be starting your treatment. So you need not remember this charts. These are the examples what I'm giving, how it works in the NHS. So in NHS, once the patient comes to the triage, they do a new scoring by entering all the vital parameters. This computer will alert depending on the score. If the score is on the higher side, the triage nurse will involve the doctor saying the septic markers ahead, and the doctor will come and assess the patient. If he also thinks that yes, this is an sepsis, he might start the treatment, and there will be no delay in the start or initiation of the treatment. That is usually followed because a wait time is very high in the NHS. So for that particular reason, you do not want to wait till the doctor has seen. So the usually triage nurse pulls up the doctor as soon as possible once they have seen the patient and feels that the patient might be having sepsis. What is neutropenic sepsis? There is a different criteria for neutropenic sepsis. Okay, in neutropenic sepsis, this is the diagnosis or this is the definition of a neutropenic sepsis. If the neutrophilic count is 0.5 or less than 0.5, okay, 0.5 or less than 0.5 per liter, then we consider this patient to be, or we are suspecting this patient to be in neutropenic sepsis. Next, what we'll be seeing whether this patient is febrile. Okay, a temperature more than 38 degrees centigrade, or your any history of fever is present, febrile. I was febrile, doctor. I had a fever of 39 degrees. If they just say I was febrile, and you're suspecting neutrophilic count to be less than point or equal to 0.5, or there are signs and symptoms suggesting often clinically significant sepsis. This is the definition, and you consider this is to be neutropenic sepsis. So remember that neutrophil count is a must, and it has to be equal to or less than 0.5. What are the causes for neutropenia? There are different causes for neutropenia. There might be a bone marrow suppression because you're taking an chemotherapy, or the patient has an aplastic anemia. Bone marrow infiltrations from leukemia, it might be certain drugs can cause like carbamazepine, certain infections can cause like an HIV infection, some immunological disorders like an SLE can cause it. There are various causes. Most of the time in the exam, they test you on the chemotherapy. So in exam, what will happen? A patient who is on chemotherapy, so chemotherapy will be mentioned. Plus, they'll be saying she or she is febrile. And usually what they do is they give all the vital parameters in the normal range. Still, we are suspecting this patient to have, might be having a neutropenic sepsis, but we cannot label it as a neutropenic sepsis because still you are waiting for the lab values. Lab value of the neutrophil count is important to make a diagnosis of neutropenic sepsis. But what does the guideline say? Guideline says whenever you suspect, that means whenever the patient is having chemotherapy and is febrile, at that point of time itself, you need to start the antibiotics after collecting the blood cultures. The preferred antibiotic here, you need to remember the name. The name is piperacillin tazobactam. Do not forget the name piperacillin tazobactam. Another factor, do not forget at the time of suspect itself. Do not wait for the full blood count. Do not wait for the neutrophilic count. Start the antibiotics immediately. You get the lab values. We'll assume that the neutrophil values are normal. Then what you can do? Then you can just prescribe on the oral antibiotics because the patient is completely stable. You can discharge them. Most of the time, there will be a protocol in place where they'll say you will be informing the oncologist also. Okay, oncologist will closely follow up with this patient and see this patient remains as a normal infection, not a neutropenic infection. The close follow-up will be done by the oncologist or oncology team. Do not offer any aminoglycosides. These patients, especially if they're on chemotherapy, they're prone for acute kidney injuries. Giving aminoglycosides will result in an acute kidney injury. Studies have shown that. That's why they prefer avoiding aminoglycosides as an empirical antibiotic. Preferred antibiotic, remember that it is piperacillin tazobactam, simply known as Piptaz in most of the emergency departments. Malaria, any fever with chills is present, and visit to an malaria endemic zone within last 3 months. Okay, for example, I visited to India in last 3 months, visited to India like 2.5 months back. Now I'm back in UK living for 2.5 months, and suddenly I have a fever with chills. Still, you need to consider this as an malaria. Okay. The test what we'll be doing is thick and thin smears. Rapid diagnostic tests are quite helpful, but most of the time it is not available in the emergency department. That's why we most of the time depend on thick and thin smear to diagnose and malaria. Ideally, this sample needs to be collected when the patient is having chills. Why? When the patient is having chills, that basically indicates that the RBCs have ruptured. Because why do RBCs rupture in and malaria? Because in malaria, usually the parasites multiplies inside the RBCs. Once there are significant amount of parasites who are present, it causes rupture of the RBCs and they spill into the bloodstream. Once they spill into the bloodstream, the patient starts having chills. Okay, because suddenly there is increase in load of parasites in your serum for that particular reason. At this point of time, if you can collect the blood sample and send it for a thick and thin smear, it is easy to isolate the parasite and observe under the microscope. What is the treatment what we'll be giving? Just you have to remember that complicated malaria is treated by artesunate. Uncomplicated malaria is treated by ACT, which stands for artesunate combination therapy. Most of the time, this might not be available, so you end up giving artesunate. So artesunate is the mainstay of the treatment for malaria. In uncomplicated malaria, artesunate combination therapy can be given. I am saying here complicated and uncomplicated malaria. What is complicated malaria then? If any one of this following is present, then we call it as an complicated malaria. Otherwise, it becomes an uncomplicated malaria. Okay, so any of this following what I'm mentioning, if present, it becomes an complicated malaria. Cerebral malaria is basically anyone who has an malaria plus he has an altered sensorium. We call it as an cerebral malaria. Severe normocytic anemia. Why does anemia happen? The same logic, because the parasites tends of multiplies inside the RBCs. They burst open, resulting in hemolysis. Whenever there is an hemolysis, it's a normocytic anemia, what you'll be seeing most of the time acutely. That's why they are having an anemia. At the same time, why do they have jaundice? Because RBCs are breaking down, unconjugated bilirubin is produced. Hemoglobin has a lot of unconjugated bilirubin. Because of increase in unconjugated bilirubin, these patients will have jaundice. And this RBCs which are broken down, the RBCs cast, kind of gets struck into the renal tubules, resulting in acute kidney injury. For that particular reason, you will be seeing an acute kidney injury also in these patients. Along with it, any severe infection can result in metabolic acidosis. Eventually, the patient can go in the septic shock. Complications of an septic shock can be pulmonary edema and ARDS can develop, but they are late complications. Liver is usually gets affected. Hypoglycemic episodes can be seen, especially in elderly people. Acidosis, most of the time, it is because of increase in lactate values. So remember that acidosis is most of the time, it's because of increase in lactate values in infections. Before I go into the central nervous system infections, let me go through the questions. Anyone is having anything? All right, we'll enter into the central nervous system infection. Again, very important. And most of the time, the people have confusions here. Most of the time, they do not get these questions right. For that particular reason, I have put across all the CNS infections together here so that they can be compared with each other and you know how to pick them up in the examination. What are the differentiating factors, what you really need to look out for? First, we'll be starting with epidural abscess. Okay, epidural abscess. We have three layers basically in the brain, or sorry, the outer covering of the brain has three layers: dura mater, actinoid mater, pia mater. Epidural, okay, above the dura mater, if there is accumulation of pus, then this is known as epidural abscess. This epidural abscess can be in your brain, that is basically intracranial, or can be in the spinal cord also. This used to be a very rare cause, used to be, but not now. Why? Because of increase in IV drug abuses. In UK, IV drug abusers, there are plenty. Because of an increase in IV drug abuses, this has become very common. Most of the time, it is in the spinal cord, which it happens, epidural abscess. It's an abscess, so high-grade fever will be there. IV drug abuse, they will be mentioning in the stem of the questions. And if it happens in the spinal cord compression symptoms will be appearing. For example, low back pain he is having, along with some deficit of the lower limbs can be there if it's in the lumbar region. So wherever the compression is there, symptoms of that particular nerves will start appearing. Most common organism causing an epidural abscess is Staph aureus. You need to treat it with antibiotics because it's an bacterial infection. Refer to the neurosurgeons because most of the time abscesses needs to be drained, otherwise it doesn't cure. Next one is brain parenchyma abscess. Okay, brain abscess means abscess which is present in brain parenchyma. It is present inside the brain. I'm not talking about the meninges here. Inside the brain parenchyma, the abscess is present. Okay, what will happen? So there is a foci which is present. This foci can discharge the electrical activities. At the same time, this foci can compress the neurons which are surrounding it. Obviously, this is a space occupying lesion which is present in your brain. So the neurons which are surrounding this, it will cause compression over those neurons. Compression over those neurons will cause focal neurological deficits will having. This is an foci to generate the electrical activities. If the electrical activity starts generating, this patient can have seizures. It can be focal seizures, which can convert into generalized seizures also. Fever, because it's an infection. There can be an increased intracranial pressure because this is a space occupying lesion. It compresses the parenchyma and occupying the space. And it develops over the time. The history will be usually in a week or more than a week's time, not less than a week's time when they're presenting to the emergency department. They'll be saying, I'm having this headache since last couple of weeks. Now I developed a high-grade fever. Now I am not able to use my upper limb and had a seizure episode. That is a classical presentation of a brain abscess. So what is the differentiating factors between a brain abscess and an epidural abscess? In epidural abscess, IV drug abuser will be present. In an brain abscess, usually they present with the seizures or in focal neurological deficit. It might be seen in a normal person also, need not be an IV drug abuser. So IV drug abuser will not be mentioned in a brain abscess. What is encephalitis? The whole brain parenchyma is infected. The whole brain is infected. What we are talking about here, the brain parenchyma, the entire parenchyma is infected. If the entire parenchyma is infected, the frontal lobe gets involved. Whenever the frontal lobes get involved, there will be alteration in the behavior. It's an infection, again, fever, some amount of headache can be there, and usually it also presents over a week's time. The common organism causing an encephalitis is herpes simplex virus, HSV. Treatment is acyclovir. Here in brain abscess, the common organism causing this is a strep viridis. We are giving antibiotics, involve the neurosurgeons because this is an abscess, might require and drainage. Meningitis. Meningitis, the outer layers, the dura mater, arachnoid mater, pia mater get inflamed, get infected. Because of infection, they get inflamed. Because of that, they classically presents with headache, vomiting, nuchal rigidity, that is neck rigidity, neck stiffness they present with. So thus the differentiating factors, what do you need to remember? Here, they classically presents with neck stiffness. Here, they'll be presenting with an altered sensorium, long history of a week's time. Brain abscess is also a long history of a week's time, but usually they present with focal neurological deficit or seizures. Here in epidural abscess, usually this abscess will cause some compression, might be focal neurological deficit, but the important parameter is an IV drug abuser. So this is an epidural abscess, what you are having here, the smaller one, what you are seeing. So remember the differentiating factors, important, very important from the exam point of view. Little bit more about the meningitis. Meningitis can be caused by viruses, can be, if it is an cryptococcal meningitis, always think of age-defining illness. It can be a tubercular meningitis also, but most of the time tubercular meningitis will have a travel history to the endemic area where tuberculosis is more common. In UK, it is very, very, very uncommon. Bacteria which commonly cause in the neonates is streptococcal agalacticae. In infants, it's a strep pneumonia again. In children and adults, again, it's strep pneumonia, which is more common. Neisseria meningitis also can cause it, but it is second most common, not very common, Neisseria meningitis. And there are usually vaccines which are available. Hence, the Neisseria meningitis occurrence has reduced drastically. They classically present with an rash. Okay, it is an maculopapillary rash, what we call it. This maculopapillary rash is non-blanching. What do you mean by non-blanching? Here I can see that this person has applied pressure using a glass, but the rash has not disappeared. If the rash has not disappeared, this is known as non-blanching. If the rash disappears, then it is known as blanching rash. What are the investigations we are getting it done? It's an infection, what we are having here. So full blood count, this is for meningitis, what I'm talking about. Full blood count, CRP, urine electrolytes, including other calcium and magnesium electrolytes, also important. LFT clotting profile, blood glucose cultures, LP, CT scan if required. Remember that whenever you're getting a CT scan, this CT scan is, you're not getting it to rule out an increased intracranial pressure. Most of the time, they will be having certain amount of increased intracranial pressure. But CT scan shouldn't be got it done to just to rule out an increased intracranial pressure. Lumbar puncture, remember that lumbar puncture takes time to perform. We are not, all of us are not very well versed to perform an lumbar puncture. For that particular reason, you shouldn't delay giving antibiotic just waiting for an lumbar puncture. You get an CSF analysis done. Questions can appear on the CSF analysis. Once you have an CSF report, how to differentiate between a bacterial, viral, and tubercular infections. In a bacterial infection, it will be turbid. In appearance will be turbid. In viral infection, the appearance will be clear. In tubercular, it will be fibrin kind of web kind of appearance will be there. When you see under the microscope, neutrophils will be prominent. Those are polymorphic cells will be prominent in bacterial infection. Lymphocytes will be prominent in viral infections. Same thing holds good in tuberculosis. Cell counts are high amount of cell counts is seen in bacteria. Around 50 to 100, 50 to 1000 is seen in viral. In hundreds, you are seen in tuberculosis. Plasma glucose levels. Bacteria usually utilizes the glucose what is present in your CSF and produces the protein. So the glucose levels will go down and the protein levels will be on the higher side. Viruses do not utilize the glucose present in the CSF. So the CSF glucose values will be more than half that of the plasma and proteins will be on the lesser side because viruses do not utilize the glucose and produce the proteins. Here the bacteria utilizes the glucose and produces the proteins. In tuberculosis, it remains again, it is a bacteria, so it utilizes and produces the proteins. Usually it will be in the range of 1 to 5. Remember that is the differentiating factors between tuberculosis, viral and bacterial. So main differentiating factor is from bacterial to the tuberculosis is the lymphocyte cells. Rest of the parameters kind of remains the same except the appearance, which also fibrin web and turbid is difficult to differentiate. Between an virus and the tuberculosis, mainly look out for the glucose and the protein values, which will help you to differentiate between a viral infection and that of the tubercular infection. Treatment, again important, you usually treat it with ceftriaxones, third generation cephalosporins. Cefotazime also can be used, but most of the time in the adults, we end up giving ceftriaxone is 2 grams BD is the dose what we usually use for meningitis. Giving these antibiotics, you should give it as soon as possible. You shouldn't delay because you're not done a lumbar puncture, you're not getting CT scan. Do not wait to get a lumbar puncture or CT scan to give the antibiotics. In most of the circumstances, along with the antibiotics, we end up giving an dexamethasone shot. Okay, remember this important, tested previously in the exam. Okay, why? The recommendation is whenever you suspect an streptococcal pneumonial infection as a cause for meningitis, it is advised that you give dexamethasone either before or just after, either before or along with the antibiotics it needs to be given. First dose of antibiotics. It is known to reduce the morbidity and mortality. For that particular reason, you are giving dexamethasone along with antibiotics are just before the antibiotics what you are giving. So do not forget that point. It is very important. Another important point is anyone who is elderly or anyone who is very young age, a neonate, ampicillin is added because Listeria monocytogenesis is one of the bacteria which can cause it. A third generation cephalosporin will not cover this bacteria. For that particular reason, you add up an ampicillin. Ampicillin or even amoxicillin can be added up. Both has good effect on the Listeria monocytogenesis. What other things you need to remember? Less than 3 months, ceftriaxone is not preferred. Cefotazime is preferred because liver is not matured. So it has to be ceftriaxone has to be metabolized in the liver for that reason. More than 3 months, again, it is a ceftriaxone itself what you are giving in more than 3 months age group also. Remember this, it is important. The parameters here is do not wait for the lumbar. Directly give third generation cephalosporins. Dexamethasone should be given along with or just before the antibiotics. In elderly, that means more than 55 years, or in the neonates, you add up and drug that is ampicillin or amoxicillin to treat the Listeria monocytogenes. Prophylaxis of meningococcal. Who does require an prophylaxis? A person who is living with that same person, for household persons, for example, father, mother will be requiring, a roommate or the inmates will be requiring. Child care center workers will be requiring if this child goes to that care center. A person directly exposed to the respiratory or the oral secretions, for example, mouth-to-mouth resuscitation you have done, or there is a kissing involved with a girlfriend or the wife, or an endotracheal intubation you have done, then it will be requiring. Airline travelers who sits beside these patients for more than 8 hours requires an prophylaxis. For prophylaxis, either you can give rifampicin or ciprofloxacin or ceftriaxone. Both or all three are equally effective. Not that one is better than the other one. All three are equally effective. Before I go into the tetanus prophylaxis, anyone has a question? Epidural abscess is only seen in spinal cords, not in brain. It is seen in both, as I mentioned in the class. Tetanus prophylaxis, tetanus prone wounds. What is tetanus prone wound? What is high risk tetanus prone wound? Remember that all high risk tetanus prone wounds are tetanus prone wounds. Okay, but not all tetanus prone wounds are high risk tetanus prone wound. Basically, what do I mean by this? A tetanus prone wound, which is very bad, is called as a high risk tetanus prone wound. Okay. What are the examples or what you need to consider? Any puncture wound, okay, required in a contaminated environment, acquired in a contaminated environment. For example, while gardening fork has struck and resulted in a puncture, then it is considered as a tetanus prone wound. Wounds which has a foreign body, it can be a nail, it can be a tooth, it can be any foreign body. A fracture is involved. A injury which has resulted in a fracture. So basically what has happened, this is an open fracture what the patient is having. Wound or burns with systemic sepsis. So basically, it is a wound. You're thinking of intestinal prophylaxis. This wound or burn has resulted in an sepsis. We know already what is sepsis. What about animal bites or scratches, which is very commonly seen because most of us have a pet animal. Most of them have a domestic pet animal. So smaller bites doesn't require any tetanus prophylaxis unless this animal lives in an agricultural setting. If this animal lives in an agricultural setting, we are assuming this dog or a cat or any pet animal goes out and scratches in the mud. So the nails might be having, the tooth might be having some amount of soil, which might have tetanus spores, can result. For that reason, it is considered if there is an agricultural setting and results in an cat scratch or a dog bite, it is a tetanus prone wound. What about high risk tetanus prone wound? High risk tetanus prone wound is any tetanus prone wound, what is there, which is heavily contaminated. For example, contaminated with soil or manure, it becomes an high risk tetanus prone wound. Extensive loss of tissue is that devitalized tissue is present like this, what is shown in the picture. Then again, you will consider this as an high risk tetanus prone wound. Wherever the surgery is required for wound or burn, there is a surgery which is required, but this surgery is delayed by 6 hours for some reason, or the presentation itself is late, then again you consider that as an high risk tetanus prone wound. What is the management for a tetanus prone wound? Again, very important. Usually a question appears. So you need to be aware of this and the management, then only you will be able to answer the question. Otherwise, it becomes difficult. Before I go ahead in answering here, let us see what is priming course. Priming course is at 2 months, 3 months, and 4 months of age, you get a tetanus vaccine according to the Green Book of NHS. So every child gets it at 2 months, 3 months, and 4 months. A vaccine is provided. A booster is given around 3 years, 4 months. That is preschool time, and 14 years. Remember, this 14 years is important because usually in the question, what they'll mention, I had taken my vaccine last time when I was in school. Now I am 30 years old. So how many years since the last dose? You need to be aware of 14 years. Now it's 30 years. So it is 16 years since the last dose. That's it's important. Complete course. When do we call it as a complete course? He has taken priming dose and the booster dose. Then we call it as a complete dose. Now let us go into this chart and have a look of this chart, what we are having here. To give and or to consider what needs to be done for a patient regarding the tetanus prophylaxis, you need to know what kind of wound it is. Another thing is what you need to know is immunization status. So two parameters should be aware. Then only you can take a decision what needs to be done. First thing what we are seeing is the vaccine is up to date. He has taken all the priming course. He has taken the boosters. The vaccine is up to date. Okay. For example, 6 months old, that means up to date means only priming course. So up to date the vaccine is, and the last dose what he has taken is within 10 years. Then doesn't matter what kind of wound it is, whether it is a clean wound or tetanus prone wound or high risk tetanus prone wound, doesn't require any prophylaxis at all. Not up to date with the vaccine. Okay, he has taken few vaccines, but it is not up to date. Or the last dose what he has taken is more than 10 years. For a clean wound, nothing is required. For the tetanus prone wound, vaccine is required. For an high risk tetanus prone wound, vaccine plus immunoglobulin is required. He has not taken his priming dose itself. The one which is given in the childhood 2 months, 3 months, and 4 months, he has not taken at all. Or he's not certain about his immunization. I don't know, doctor. I do not remember. I am 70 years old. I don't know. Or he's the person who was born before 1961. It is important, 1961. So 39 plus 24 included. So 13 what we are having. So 63. Anyone who is 63 for you is the mark what you need to remember, because they can directly give you the age. Then you might have to calculate the born before 1961. For that particular reason, I'm giving this reading. It is important what you need to remember. For them, if the wound is clean, you give an vaccine. If it is tetanus prone, vaccine plus immunoglobulins are different side. Here, again, vaccine plus immunoglobulins, if it is high risk tetanus prone, also you'll be giving. So all these three boxes requires vaccine plus tetanus immunoglobulins. Remember that has to be given intramuscularly, that is IM, and in two different sites. For example, if you're given at the right gluteal region, the other one should be in the left gluteal region, what you're giving it in two different sites. What is the dose of tetanus immunoglobulins? They are available in international units. So how many international units you are giving? If the patient presents within 24 hours of the injury, then you are giving 250 international units. If he presents after 24 hours of injury, then you are giving 500 international units. Very important. Usually a question appears, be aware of this. Why do we give tetanus prophylaxis? Why are we scared about tetanus so much? Because the mortality rate is very, very high. Almost 99% is the mortality rate anyone who has an tetanus. It is a clinical diagnosis what we'll be having. Here, what you are basically looking is spasms, what you're having, difficulty in opening mouth, general whole body spasmed, even the trunk muscles are spasmed here. You get and serum toxin or serum IgG levels can be done, but it's mainly the clinical diagnosis. You need to have a good history of an injury, no vaccines taken, and multiple spasmic episodes the patient is having. What you do is wound debridement, wound cleaning that has to be done, and IV immunoglobulins what you'll be giving for these patients. Certain few parameters, if it is a poke, remember that it is tinea solium, what you need to remember. Beef, tinea saginita, what you need to remember. For both, the treatment is praziquantel. Another thing from GI tract, we talked about the meat. Okay, meat, whenever meat question comes, see whether it is an cold meat when they are talking about or they are talking about a raw meat. If it is a raw meat, the most common organism causing the infection is E. coli. If it is a cold meat, the most common infection which causes gastroenteritis is listeria, what you need to remember. For example, they have mentioned meat, but they have not very classically mentioned whether it is a raw meat or cold meat, or in the options only listeria is given, E. coli was not given, then choose listeria. Only E. coli is given, listeria is not given, then choose E. coli. But they have specifically mentioned meat, and it is a raw meat, and E. coli is in the option, choose E. coli. It's a meat, cold meat, and listeria is in the option, then choose listeria. Viral hemorrhagic fever and risk assessment. When do we consider as a viral hemorrhagic fever, like in dengue fever? When do we consider it as a dengue fever? In UK, I'm talking about. Anyone who has a history of fever or currently is febrile where the temperature is more than 38 degrees Celsius, or history of fever in last 24 hours. He has a history of travel where this fever, basically the infection is endemic. For example, dengue fever is endemic in most of the places in India. Okay, so you consider there is a travel history? Yes. Or he has been exposed to a person who had this infection, or exposed to an animal, or basically working with one of these specimens like blood, urine, feces, or blood cultures of the patient who has been basically infected by this viral hemorrhagic fever. Then also you consider this patient to might be having as an viral hemorrhagic fever, and you need to do a thorough evaluation. Little bit more about the dengue fever. Dengue fever is mainly caused by a mosquito, a group of mosquito known as Aedes aegypti mosquito. It classically presents with fever, headache, nausea, vomiting, severe malaria, viral like a viral infection. Nothing specific is there. Okay, similarly, and viral hemorrhagic fever can present is West Nile's fever. How do you differentiate between dengue and West Nile's fever? Similar presentations, but also has a lymphadenopathy in West Nile disease. There is no lymphadenopathy present in dengue fever. That's the differentiating factors. In a later stage of dengue fever, the patient can have bleeding diathesis. Diagnosis is done by serology. Usually, whenever the patient is having a dengue fever, the hematocrit values will be on the higher side, mainly because of dehydration. They will be severely dehydrated, so IV fluids will be given. For that reason, hematocrit will be on the higher side. Low WBCs and platelet counts will be on the lower side. Low platelet counts is the one which causes the bleeding. They can bleed from anywhere, from intracranial bleed to gum bleed or urinary tract bleeding. The management remains supportive. NSAIDs or aspirins are not preferred, mainly because they have antiplatelet effect, and this patient will be having low platelet count. That's why we do not prefer giving NSAIDs or aspirins in this patient. You need to avoid it, give some other drugs to manage. Like for fever, just give paracetamol. Do not give NSAIDs like ibuprofen or diclofenac. Combination of low platelet and antiplatelet effect might result in bleeding. HIV infection. You need to be aware of CD4 counts. Okay, CD4 counts usually in a normal person who doesn't have an HIV infection, it ranges from 500 to 1000 cells. Okay, typically the CD4 counts are checked in an HIV patient every 3 to 6 months. HIV is just an infection. AIDS is the syndrome. It takes around 10 years to develop the AIDS. From HIV to AIDS, it approximately takes 10 years. When do we start the treatment? We start the treatment, antiretroviral virus treatment, when the CD4 counts falls less than 350 cells. But when do we call it as an AIDS? We call it as an AIDS if the CD4 counts are less than 200. But the treatment is started when it is less than 350 itself. Antiretroviral treatment is started when it's less than 350 itself. Whenever someone is exposed to an HIV infection, how long or what is the minimum duration for it to appear in the serum and your test comes as a positive? Like Western blot test, how long it takes for it to come positive? Or an P24 antigen test, which is the most specific test, how long it takes for it to turn positive? It takes around 1 to 6 weeks. For example, you got an exposed, you were cannulating an HIV patient, and unfortunately, you ended up having a needle stick injury. If you immediately get your blood test done, is it helpful? No, because it will come negative. Your serology or your serum will not have this HIV infection for at least minimum of a week. Usually, it takes at least a month's time for this test to turn positive. So immediately checking is useless. So we never check immediately if there is an exposure to HIV. We ask them to wait for weeks together, then come back, then we'll be checking. Now we are entering into the needle stick injury. Again, very important from exam point of view. Multiple questions have appeared, might appear in your exams also. When do we call it as insignificant fluid? Significant fluid, easy way to remember is other than urine and feces, all other fluids is considered as insignificant fluid. For example, blood, internal organ fluids, semen, vaginal secretion, saliva, everything is considered as an significant fluid. When do you consider as an significant exposure? Whenever the exposure is for exposure has breached the skin. When it might happen, when you're using a sharp object which has resulted in breaching of the skin, or there is already a broken skin present because of an abrasion, wound, or eczema, and there is spill of this fluid, the significant fluid what we spoke about, or splash into the mucous membrane. There is no skin on the mucous membrane, so it can easily enter into a systemic circulation. For example, over your lips, over your eyes, splash over your lips, especially the oral cavity, over your eyes, mucous membrane. High risk. When do we call it as a source as high risk? Source as high risk. Whenever he is an IV drug abuser, he works in a sex industry worker. It just doesn't mean a sex worker. Anyone who works in the sex industry itself is considered as an high risk. Anyone who is a virgin from an sub-Saharan or Southeast Asia, Latin America, or Caribbean, they are considered as an high risk. Whenever anyone has intercourse with any of these three above mentioned without any protection, unprotected sex, then they end up or they are considered as an high risk. Men who have sex with men, this basically means anal intercourse. Anyone who has an anal intercourse, persons who are having multiple sexual partners, more than one sexual partners, again considered as an high risk. A child is considered as an high risk if the mom is HIV positive. Okay. Or the source is diagnosed as an AIDS high risk, it becomes, or under investigation, it becomes an high risk. He may not fall in any of this above 7 categories, but he's in the investigations for AIDS defining illness, or he is suspected to have AIDS, or he's already been diagnosed with an AIDS, he becomes an high risk. So what we do in the emergency department, if someone comes with a needle prick injury, most of the time the needle prick injury will be seen in healthcare workers. A healthcare workers, out of hours, he comes to the emergency department. Why out of hours? It is important. If he comes to the emergency department within working hours, for example, between 9 a.m. to 5 p.m., he presents to the emergency department with a needle stick injury, we refer them to the occupational health. They will take care and they will do what is necessary. Out of hours, that is, occupational health is closed, they cannot go there. At that point of them, they end up coming to the emergency department. So what we do? What we do is we collect the samples, that is blood sample is collected from the patient who had, from the person who had a needle stick injury. These samples are collected and stored. Okay, it is not processed, it is just stored. Because if you immediately do, it will come as negative. So no point in immediately doing the test. But why do we collect and store it? There should be some reason. We collect and store it because there is a little bit likelihood that this patient might be already having an hepatitis B infection or an HIV infection or hep C infection itself. Okay. For later on stage, if he's diagnosed with an HIV, we need to know that if this patient had this infection before itself, or this was because of needle stick injury. For that reason, would have stored it. If in the future required, we'll be using it. If the source is known, I know from this patient, this needle was withdrawn, and that through with that needle, I got a needle stick injury. That means you know the source. You take the consent from the source and collect the blood samples for hepatitis B surface antigen, hepatitis C infection antibodies, and HIV antibodies. So three H's we are getting: HIV, hepatitis B, and hepatitis C. Basically, we are testing it for. You need to always get the consent of the source. Okay, without consent, you cannot get the sample. And for example, there is a registrar from acute medicine who has got it. Whether that registrar goes and takes the consent, or you as the treating doctor goes and takes the consent, you as a treating doctor should go and take the consent, not the person who had the needle stick injury. You need to remember, not the person who had the needle stick injury. What if the source, that means from whom we are suspecting might be having hepatitis B or C or HIV infection, the source doesn't have the capacity. For example, he is intubated patients. You cannot take the consent from him. Or he is a psychiatric patient. He is not oriented to time, place, person. What do you do at that point of time? Then you treat it best interest of the patient. That is the source. So what is the best interest for the source? Do not collect the blood sample. What is the immediate management? Immediate management is liberally wash with soap and running water. If it is the mucous membrane, which is then liberally irrigate with and running water. Conjunctiva also should be before and after the removal of contact lens needs to be closed if the person is using a contact lens. Puncture wounds, if this is there, you need to allow it to bleed. Do not squeeze and try to remove more and more blood. That is a dirty blood. I'll remove it off. No, that doesn't work. It might cause more infection. Do not try to suck it out or do not try to squeeze it out and remove more blood. If it is bleeding, just allow it to bleed and wash it in a running water with soap and running water. Do not squeeze and try to remove more blood. Do not suck it out. What is the HIV post-exposure prophylaxis? You need to consider really in these patients, because whenever there is a deep injury or visible blood on the device which is involved, for example, it was an cannula and you removed, and the needle of the cannula has blood visible on that. Injury from a needle that has entered the source blood vessels. That is again cannula, what we are talking about. Terminally HIV related illness the patient is having, who is about to die because of the HIV illness what the patient is having. Okay. These are considered as a very high risk patients for an HIV, including the previous ones what we have spoke about. These are the previous ones what we are really spoke about. Source being high risk, significant fluid, significant exposure. What do you need to remember? Sorry. What about using double gloves? There is not enough evidence to say using double gloves will be helpful. If it is an high risk source, for example, someone had an anal intercourse, what are the chances? If the patient asks you what are the chances of being getting an HIV because it is in high risk, it's only 0.3%, not more than 0.3%. Load is undetectable. For example, I had an intercourse with an HIV positive person, and recent investigations of his shows that load is in that undetectable. What is load? Load is viral load we are talking about. Undetectable means less than 200 copies. No need for prophylaxis. Unlikely that person will cause you an HIV. Ideally, this HIV prophylaxis should be given within 1 hour. Till 72 hours also you can give it. Beyond this, it is not recommended. The dose for the HIV prophylaxis is mentioned here, or the drugs is mentioned here. You can remember it for your own knowledge. It is not required from the exam point of view. Whenever you're giving an HIV prophylaxis, it shouldn't be taken with rifampicin. Okay, it should be taken at least 8 hours after taking any vitamin supplements, calcium, iron, or magnesium supplements. Oral contraceptive pills, if they are on, tell them to use biocontraceptive, because the oral contraceptive pills effectiveness might decrease with an post-exposure prophylaxis of an HIV. In pregnancy, it is inquiry whether we need to really push for post-exposure prophylaxis or not. But the recommendations are, if they are pregnant, you still go ahead and give them an HIV prophylaxis option if it is an high risk. Okay, if it is high risk, then only we are offering an HIV prophylaxis. Remember that if there is no high risk, you're not giving any HIV prophylaxis. For example, it is not it is not in sub-Saharan episode, and it is not an intercourse. It is not an sex worker. Then these are all not high risk. He's completely fine, normal person. You had in sexual intercourse. Do you give an HIV prophylaxis? No, we do not recommend those people to get an HIV prophylaxis. If there is any high risk involved, then only we give an HIV prophylaxis. If it is pregnancy, still we offer an HIV prophylaxis, but it is always recommended get an pregnancy test done before giving an HIV prophylaxis so that you are aware that this patient is pregnant before you give the HIV prophylaxis. What about hepatitis B post-exposure prophylaxis? It is a bit complicated. You need to remember this. There is no option. It is complicated. I do agree, but you need to remember this for the exam. It's been tested previously. It's not that it's not been tested. The things what you need to consider: significant exposure. We already know what is significant exposure when it breaches the skin. Non-significant exposure when it does not breach the skin. Okay, HIV positive, the source, you know it is HIV positive. You don't know who is the source itself, or you know the source, but HIV, hepatitis, sorry, not HIV, it is Hep B negative, Hep B positive. So you know the source is Hep B positive, you know the whole source is Hep B negative, or the source is unknown. In non-significant exposure, whether there is continued risk or no continued risk, what you need to remember. Okay, non-significant exposure and significant exposures are different. In non-significant exposure, we are seeing continued risk and no continued risk. We're not saying whether the source is positive for Hep B or negative for Hep B or unknown. We are not saying continued risk. What is continued risk? Is there a continued risk of this person having a needle stick injury or no? No, he is a normal person. Unfortunately, he had once he visited the hospital, ended up having a needle stick injury. For that person, it's not required. Okay. What is next parameter? What you need to aware of is the person vaccinated, partially vaccinated, not vaccinated, partially vaccinated, fully vaccinated. He's vaccinated, but he's not responding. What is vaccinated and not responding? That means he's been vaccinated, but if you draw his blood and check for the antibodies, there are no antibodies which are being produced. Okay, this vaccine is ineffective for this person. So vaccine what he has taken is not effective. It doesn't mean everyone who gets an vaccine will get the immunity. These persons are not getting the immunity because of the vaccine. After taking vaccine, also they're not getting the immunity, these persons. First, we'll be saying if the source is positive and he's unvaccinated. That means what? You can logically reason it out. Source is positive, he's unvaccinated. Chances of infection are high, so you will end up giving immunoglobulins and start vaccinating the person. He's partially vaccinated. He's partially vaccinated and source is positive, so you will end up giving one dose here and ask him to complete the course. He's fully vaccinated, then you can give a booster dose if the last dose is more than 1 year. He's a non-responder. Chances of infection are very high because the source is positive here. Give them the immunoglobulin. Consider giving booster. And second dose of immunoglobulins is given after 1 month. Okay. That's what is for if the source is positive. If the source is unknown and he is not vaccinated, start him on accelerated Hep B vaccine course. Partially vaccinated, one dose of Hep B vaccine goes and finish the course completely. Here is the same. Consider giving hepatitis B booster dose if it is given more than last dose was more than 1 year ago. Here, what happened here is again immunoglobulin is required. So three circumstances we are giving immunoglobulins here. Unknown source, non-responders. Known source and positive, non-responder. Known source and positive and unvaccinated. Again, these are the three constituents we give immunoglobulins. Next one is Hep B negative. No chance of infection because there have been negative already. Unvaccinated, consider giving vaccinations as routine. Complete the course because it is partially. No Hep B prophylaxis is required here. No immunoglobulins. Consider giving booster dose. Anyways, they are not responder. Consider giving it if required. Give it if your protocol says it. Otherwise, do not give it. In non-significant exposures, is there a continuous risk? Continued risk is there, then give the immunoglobulins because give the Hep vaccine. Otherwise, you're not giving the vaccine because continued risk is there. So give him vaccines because next time around it might be a significant exposure. That's why start hepatitis B vaccines here itself in the AD. Partially complete the course. No prophylaxis is required here. No immunoglobulins, but consider giving a booster in a non-responder. In a non-significant exposure, no further risk is there. Don't give anything. Not required. Same thing holds. Sorry. Same thing holds good. Don't give any prophylaxis. You have started giving, then give the prophylaxis. So no further risk, non-significant exposure. You already started partial. That's why you're completing the course. Otherwise, you're not giving, not giving, not giving, and not giving. So you can logically reasoning it out. Make a tabular form in your home and logically reason it out. Whether I'll give it, let me make a sense of it, whether I'll give it or not give it. In that way, you can remember it. In exam also, it becomes easier to recall in that manner. Hepatitis C post-exposure prophylaxis, they do not exist and post-exposure prophylaxis for Hep C. If the source is found to be Hep C positive, what you'll be doing, just refer to the occupational health. All these patients, you will be referring to the occupational health. Eventually, they need to follow with the occupational health. And it is a needle stick injury. Incident reporting has to be done because it's an hospital setup and needle stick injury has happened. It is an incident which needs to be reported. So incident reporting has to be done. So if it is out of hours, then they come to the emergency department. Otherwise, you are referring to the occupational health. Significant exposure is there. No, not there. Just reassure and discharge. Significant exposure is present. Yes. Source is known. Yes. Then collect the source blood samples after taking the consent and test for the HIV. If the HIV is positive or at high risk, consider giving an HIV prophylaxis if they are presented within 24 hours. Otherwise, HIV prophylaxis is not recommended. Consider hepatitis B prophylaxis as per the chart what we have learned so far. Always refer them to the occupational health. Do an incident reporting for anyone who has a needle stick exposure. This basically summarizes the everything what we have, or put it in across in a tabular form or in flowchart manner. What about needle stick injury in a community? Usually, we do not recommend giving any prophylaxis here. For example, it is an HIV. We do not give because HIV cannot live in an external environment. Though they thrive inside your body and it is almost impossible to kill an HIV virus in your body, but they do not survive in an external environment. They can hardly survive for 2 hours. After that, they do not survive in an external environment. That's why it is not preferred to give an post-exposure prophylaxis for an HIV. For hepatitis B, it's similar to the healthcare workers, what we have learned, the complicated chart, that one same thing in holds good. For donor patients, may also present to the ED sometimes. For example, they are IV drug abusers. So they have shared the needles, then they realized he was HIV positive. For those persons, check for blood-borne viruses stated, that is an Hep B, Hep C, and HIV you need to check for. Okay. And according to the results, you will be taking call how you have treated the other patients. Remember that HIV, one thing you are not giving it. Hepatitis B, how we have treated healthcare workers, like that we are treating the person. Next one is animal bite. Animal bite, humans are also animals. So human bite, cat bite, dog or any other traditional bites are considered in this column. If it is a human bite, first we need to see the wound. Okay, whether the bite has broken the skin or not. If it has not broken the skin for any kind of bite, you're not giving the antibiotics. For example, it has just licked your skin. Do I need to take an antibiotic? No, not required. Bite has broken the skin but not drawn blood. There is no oozing of blood was present. So do not give any antibiotics if it is a dog. Just you consider giving antibiotics if it's a deep wound, if it is present, if it is a cat bite. In human bites, if it is a high risk area or a high risk person, you are giving it. What is high risk area? High risk area is where there is terminal arteries are present or there is a poor circulation is there. Poor cartilaginous structures like your ears are poor cartilaginous structures, nose are poor cartilaginous structures. So face, genitals, feet, hands. Okay, these are the either end organs are present or poor circulation is present. High risk persons are the persons who are immunocompromised because of a diabetic or no spleen is present or decompensated liver disease is present. Give antibiotics in those or consider giving antibiotics in those who had a human bite. What about if the bite has broken the skin and drawn the blood? Then you offer the antibiotic for both human and cat bite. But in dog, you consider giving antibiotics if it's a high risk or high risk area or a person. Same thing, no changes. Or there is extensive loss of tissue is present, then you consider giving. So for dog, we have very high threshold of prescribing an antibiotics. For humans, we have the low threshold, and cats also we have the low threshold to prescribe the antibiotics comparatively what I'm talking about. Usually the antibiotics preferred is coamoxiclav. If you're interested, you can remember it, but you need to remember coamoxiclav is the routinely used both adults and children's. Coamoxiclav is the preferred antibiotic. If it is a penicillin allergy, depending on the age, it changes, but usually will not be tested. If they test, they'll be asking which antibiotic usually given for human bite, coamoxiclav cat bite, coamoxiclav dog bite, coamoxiclav. List of notifiable diseases. There are plenty of notifiable diseases. Disease and notifiable organisms are plenty are there. These also notifiable organisms, plenty are there. But at least in last 5 diets, a question has appeared on notifiable organism. Every time it will be on Epstein-Barr virus. Okay, Epstein-Barr virus is not a notifiable disease. It's the same question which has appeared every time on the notifiable organisms. They have not asked any other organisms at all. Only another one which has appeared is malaria. Malaria is a notifiable disease. Okay, you need to notify this. Okay, this is notified. These are the two things which has appeared. Most of the time it is EBV which has appeared. Okay, at least remember this, because remembering the whole chart is very difficult for me. If you're good at remembering things, then go ahead and remember. How to notify, or when do we notify? Once you suspect itself, you notify it. Suspect, notify immediately. Do not wait for the laboratory investigations, because most of the time, for example, malaria thick and thin smear might take longer time for you to get the report. So whenever you suspect itself, you notify. Within what time you're notifying it? Within 72 hours, you're notifying it. In certain special circumstances, you'll notify it within 24 hours. When do you notify within 24 hours? Wherever it is mentioned as urgent, 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 those disorders or those diseases, you, you notify within 24 hours. Other diseases, you can take time up to 72 hours. You can notify them. That is nothing but 3 days. How do you notify? Either you can do a phone call, letter, or send them an email or fax machine. Usually we email them nowadays rather than phone, letter, or fax them. Is the email what has been followed. Encrypted email is what has been followed. I'll go through the questions. Before going questions, I'll go through any doubts you are having. Can you explain born before 1961 again? So anyone who is born before 1961. Okay, as simple as that. Anyone who is born before 1961. Okay, if the patient is born in 1959, his date of birth is 1959. That is considered as an born before 1961. Why we are considering born before 1961 is before 1961, the tetanus prophylaxis was not included in the vaccine schedule of the UK. In Green Book of the Vaccine Schedule of the UK, tetanus prophylaxis was not included at all. For that reason, we say born before 1961. That's the logic behind going to 1961. So I do not see any other questions. So we will enter into the recall questions, what I am having. If you have any doubts, please mention the question of which question you are having the doubt. An elderly female came to the ED with complaints of pain while passing the urine and increased frequency. So I'm already thinking of an urinary tract infection in this patient. She's a known case of breast cancer on chemotherapy. Chemotherapy in an infection, think of neutropenic sepsis here. Because chemotherapy, infection. The last chemotherapy session was 10 days back. She's generally well, but her doctors has suggested her to visit the ED, that the oncologist must have suggested to visit the ED. The vital parameters seems to be fine. She's afebrile in the emergency department. What is the next step in management? What we have learned, this is a suspected case of neutropenic sepsis. Treat it like an sepsis or give them the IV antibiotics. The preferred IV antibiotics is piptas needs to be given in the emergency department. So out of the options here, where is the IV antibiotic? Only in the option 5 has the IV antibiotic here. Along with it, you need to always send for full blood count and collect the cultures because you are giving intravenous antibiotics. So the right answer here is the 5th one. You request the nurse to draw a blood from a patient for investigation. The nurse accidentally pricked herself while doing so. She immediately washed her hands with the running water. The first step is already been done. The nurse in charge has asked her to meet you to discuss the needle prick injury. She is immunized against hepatitis B. So she is immunized. Which one of the following history of the patient is a high risk for HIV? Sub-Saharan traveler? No. Sub-Saharan habitat. They are originally from Sub-Saharan. So they are from there, not and just a visit to Sub-Saharan Africa makes them an high risk. Blood transfusion in the UK before 1991 is no, it's not considered. Blood transfusion in USA, no. Semen splash, no. Anal intercourse, yes. This is considered as a high risk factor for HIV. So 5th one is a high risk factor. A 6-year-old boy was brought to the emergency department by his worried father. He complains of lethargy and abnormal vision. Lethargy, abnormal vision, lash over lower limbs. He was seen by a GP a couple of days back, which has not improved. His observations are given here. He is febrile, what I can see here. Has a maculopapillary rash, which is noted over the lower limbs, which doesn't disappear on applying pressure. That is known as, in other terms, it is a non-blanching rash what the patient is having. What is the most probable diagnosis? Non-blanching rash, whenever it comes, think of meningococcal infection. So it is a meningococcal infection what we are having here. So out of this, where is the meningococci is mentioned only in one option, meningococci. So meningococci septicemia, what you need to suspect. Remember, in pediatric age group, the signs and symptoms what they present are very vague. Okay, lethargy, abnormal vision, rash in the lower limbs, high grade fever. So very vague symptoms. They're not very specific symptoms. It's very difficult to find out the source in a pediatric age group because the symptoms are very vague in the pediatric age group. So usually they present with the vague symptoms. Remember that point. A 39 years old male, anal intercourse, you say it's unprotected. I did. It is an anal intercourse. Okay. Male having a sex with male is an male. I didn't say unprotected sex. I said unprotected sex with top three more. What were the top three more causes which were mentioned? Those were anyone within a sex worker or anyone working in a sex worker. Those are considered as unprotected sex with anyone who is having the top more. It is not considered anal intercourse with protection or without protection. It is considered. I'll clarify here. You, I have not mentioned it. Clearly, men who have sex with men. So please concentrate in the class. If you miss each point what we teach, will eventually will cause you your exam. 1 mark lost might be the result which will be like pass or fail in between. So concentrate in the class what we are teaching here. Another question is how to differentiate between meningococcal and HSP. HSP itself, which is an hematocolon purpura, which we have not learned, it presents classically with the symptoms which will have periarticular swelling, that is joint swelling will be present, arthralgia will be present, joint pain will be present, some amount of abdominal pain will be present, kidney injury along with the hematuria will be present. Usually it is presented around the 5 years age group. Nothing of this following is present here really to suggest of an HSP for this patient. A 39 years old male presented to the ED department with complaints of fever associated with chills. He gives a history of recent travel to India where he had contact with a person who was suffering from an malaria. So there is a contact. You're strongly suspecting an malaria now. Extremely lethargic, has presented to the ED, is no comorbidities, paracetamol he has taken. You strongly suspect in malaria, hence blood has been drawn for thick and thin smear. Which one of the following statements are true regarding the malaria is the question here. Can you discharge? You do not discharge any malaria patient in the UK. Reassure as malaria is not a serious disease. It can be serious disease, can cause death. Full blood count helps with the diagnosis. No, it's a thick and thin smear or rapid diagnostic test what is required for the malaria. Malaria is a notifiable disease in the UK. Yes, absolutely right. There is no specific treatment for malaria. Absolutely, there is a specific treatment. Artesunate in a complicated malaria, uncomplicated malaria, artesunate and combination therapy what is given. A 70 years old farmer present to the ED with a dog bite over the face as shown as in the image. So this is the dog bite what you are having here. Over the face, it is, he denies any other injuries. He is a known case of osteoarthritis and hyperlipidemia. On examination, there is a lacerated wound over the lower lip. He is unsure about the tetanus prophylaxis. He is unsure about the tetanus status. A decision has been made to give the immunoglobulins. What was the factor which led to this decision? Why are we giving this decision? Here, farm setup is present. This is a farm. So agricultural setup is present. Along with it, this is a puncture wound. So it becomes an tetanus prone wound. And he doesn't remember his last dose of vaccine when he had it. So where we'll be going? It's a tetanus prone wound. And sorry, unsure about the vaccinations. He's unsure about or uncertain about the vaccinations. For this reason, we are giving it a tetanus immunoglobulin for this patient. Because it is a tetanus prone wound and unsure about the immunization, for that reason, we are giving immunoglobulins for this patient. A young female presented to the ED with complaints of lower abdominal pain worse before opening the bowel. She gives history of diarrhea since 3 to 5 days, which is getting worse. She has been on a trip with her friends where she ended up having cold meat. Her observations are as follows. There is a febrile fever is present, otherwise it is fine, which is the causative organism they are asking. Cold meat, always choose Listeria. Raw meat, always choose E. coli. If they have just mentioned the meat and depending on E. coli or Listeria they have mentioned, just choose one of those. A 5 years old was brought to the ED by his mother, was playing with the younger brother, ended up with an arguing. He got and bitten over the brother's right hand as the picture is shown here. His vital parameters are normal, systemic exam is unremarkable. The image is given what is the most appropriate management plan for this patient. This the skin is erythematous. There is a swelling which is present. We are suspecting there might be an underlying abscess. So abscess, you need to suspect it looks like an abscess. There is a swelling. There is an erythema which is present around the bite. What is there? So human bites are usually what we do. Though it is a bite, even though it is bite, we are not sure whether blood is drawn or not, but still requires an antibiotic because we are thinking of an abscess, and requires an drainage because we are again thinking of an abscess. Remember, any abscess is there, we always drain it. So coamoxiclav with with drainage is the right answer. One of you have a doubt here. Question number 5. Why not patient's age? Does only patient age? You have the age here. You do not know what is the wound status. Will you give the immunoglobulins? You will not give the immunoglobulins. You need two factors here. That's why I told. You need to know what is the wound, what is the immunization status. That's only present in the option 3. Here, you just know that age. Age is known. That's all. What about the tetanus status? What about the wound? It is not known. You cannot give immunoglobulins directly because if it's a clean, you will just give the vaccine. You'll not be giving the immunoglobulins. So this is a wrong answer. A 60 years old female unknown case of chronic kidney disease on dialysis presents to the emergency department complains of fever with rigors since morning. She has a perm cath in situ for dialysis. Okay, these are the observations where the patient is having a high grade fever. What is the initial step in management? There is an infection. There is an foreign body. This is a perm cath. Perm cath is nothing but this is a permanent catheter what they have inserted so that they can perform the dialysis over the time. Okay, most of the time perm cath is taken as a last resort when all the fistulas and the options for the fistulas have exhausted and you want to perform the dialysis. At that point of time, you go ahead and insert an perm cath, usually directly into the subclavian vein what they'll be inserting the perm cath. So this is a foreign body. You need to suspect there might be infection from the foreign body. So collect the cultures from there before you give the antibiotics. So what you'll be doing, collect the cultures from the site of the perm cath is the first option. What you need to remember. That is the right answer here. What you need to remember. Another thing here is most of the time, if it is a foreign body, what we do is we remove the foreign body and give it for culture. For example, central vein catheter is there. Okay, central vein catheter, how do we do if you're suspecting an infection there? We remove the catheter, send the tip of the catheter for culture. Do we do the same thing for the perm cath? We do not do the same thing for the perm cath because perm cath is required for the dialysis. If you're very, very strongly suspecting, get another source for the dialysis, then remove the perm cath and then remove the perm cath. Because if you remove the perm cath, you cannot do an dialysis for this patient. Okay, for that reason, drastic steps shouldn't be taken unless and until it is very much suggestive of an infection from the perm cath. For example, uh, pus is oozing out from the perm cath. At that point of time, you can remove the perm cath or you have to remove the perm cath. A young male came to the emergency department with post-exposure prophylaxis for, requesting post-exposure prophylaxis for HIV. He gives an history of having an unprotected sex with an unknown person. He denies any similar activities in the past. He has no known comorbidities. He has taken, doesn't take any prescription medication for illicit drugs. Which one of the following is not an high risk for HIV? Not an high risk. Intravenous drug abuser, yes. Sex worker, yes. Originally from sub-Saharan Africa, yes. Anal intercourse, yes. Smoker, any kind of smoke you do it, it's not a high risk for HIV. Which one of the following parameters are not suggestive of CIS? CIS stands for Systemic Inflammatory Response Syndrome. Which one of this is not suggestive of? Sorry, is suggestive of they're asking, which is present in the criteria they're asking. Urea is not present, lactate is not present, oxygen saturation not present, blood pressure not present. New onset confusion, yes, present. Along with the temperature is present, heart rate is present, respiratory rate is present, WBC count is present, altered or new onset confusion is present, and blood glucose level in the patient who is not been diagnosed with diabetes is present, which is more than 7.7 millimoles per liter. So remember the criteria, CIRS criteria. A 67 years old male has been to a pub, celebrated his birthday with his friend. He tried to stop a fight between two ladies. One of the ladies has bitten his forearm. There is there are no other injuries sustained. He is a known case of hypertension and diabetes on multiple drugs. On examination, vitals are stable. A bite mark is noted over the right forearm. The skin is broken. Blood is not drawn. What is the indication to give an antibiotic? So when do we give an antibiotic when skin is broken and not blood drawn? when it is an high risk person or high risk area. Is he a high risk person? Yes, he is a high risk person because he is a known case of diabetes. So diabetes, for that reason, we are giving the antibiotics. Is it a high risk area? No. Forearm is no. Hand is high risk area. Forearm is not. Which one of the following is not included in sepsis 6? Monitor the urine output included, measuring lactate included, oxygen, yes, antibiotic, yes, steroids is not included in sepsis 6. You can see here sepsis on different criteria, they have the questions. Here, though this much is mentioned, they are just concentrating on this one. Which one of the following is not included in sepsis 6? A 3 years old child was brought by his mother to the emergency department with an puncture wound to the foot with a soiled garden fork. This itself makes this patient an high risk. Make this patient as an high risk tetanus prone wound. Okay, it is a high risk tetanus prone wound because it is contaminated with the mud and it is a puncture wound with a garden fork. He have been recently immigrated from Georgia and there is no previous history of vaccination. Development is appropriate to the age and there are no previous hospital admissions. You have cleaned the wound and dressed it according to a green book. What is the best that can be done regarding the immunization? Because he's not immune at all. He's around 3 years old. Around 3 years old, according to the green book, what can be given? TPT and polio can be given along with the MMR. So what will be giving here? So this patient requires tetanus plus requires an immunoglobulins because he's not vaccinated and in high risk tetanus prone on. Along with he's a 3 years old. So at the same setting, you can give an DPT vaccine and MMR vaccine. So options which are included, options which are included here, diphtheria, tetanus, polio, along with tetanus immunoglobulins can be given. That's why the right option is the third one, not the second one. They are asking what is the best can be done regarding the immunization. The entire question, you need to know the immunization schedule also to answer this. This had appeared in the FRCM exam. Okay, according to the question, what they have asked, right answer is third because his age is 3. He has not taken any vaccines. You can give around 3 years, 4 months, you can give DPT and MMR vaccines along with the tetanus and tetanus immunoglobulin. DPT includes and tetanus, so just you need to add up and tetanus immunoglobulin. A 23 years old female who is very anxious came to the ED with her vital parameters being normal. She is requested post-exposure prophylaxis for HIV. She has an history of sexual intercourse with her partner who is a male and the condom has broken during the intercourse. She's not sure if she has leak of seminal fluid. Her partner is HIV positive and recent blood investigation shows undetectable viral load. What is the most appropriate next step? Undetectable viral load. Whenever there is undetectable viral load, no post-exposure prophylaxis is required. Okay, as taught you in the class itself, in the previous slides, reissue and just discharge. No post-exposure prophylaxis is required for this patient. A young male came to the ED requesting HIV prophylaxis. He gives a history of attending a rave party last night where he smoked marijuana, ended up having unprotected sex with a male partner. He doesn't know anything about his past medical history or professionalism. Which one of the following is in high risk for HIV? Anal intercourse with substance? Yes. South Korea? No. Vaginal intercourse? No. Smoker? No. Kissing? No. Kissing, remember that kissing is not an high risk. It's an intercourse. Okay, it's an anal intercourse specifically, which is an high risk. A student nurse accidentally pricked herself when she was discarding the IV cannula set. Unfortunately, she has not wearing any gloves. In in charge nurse has requested you to talk to her regarding the needle stick injury. You have washed the needle prick side with the running water. If the donor source patient is unconscious and you're unable to uncertain the risk, what should be done? You cannot collect the blood samples from the donor because he's unconscious. You cannot get the consent. At that point of time, you'll just collect the sample from the recipient and refer him to the occupational health. Along with it, usually we do an incident reporting also. For that reason, the first one is the right answer. So collect the sample from the recipient, refer to the occupational health and incident reporting. You're not collecting the sample from the source to do any investigations. A 58 years old male presented to the ED with complaints of fatigue and dizziness. He gives an history of a burning sensation while passing urine and increased frequency since last 3 to 4 days. He is a known case of myasthenia gravis and rheumatoid arthritis. His observations are given where it is completely febrile here. Which one of the following antibiotics to be given for this patient? Remember that myasthenia gravis, three groups of antibiotics are contraindicated. That is, either you shouldn't be giving quinolones, you shouldn't be giving macrolides, and you shouldn't be giving aminoglycosides. These are the three groups of drugs which are contraindicated in anyone who is having an myasthenia gravis. So out of these options given, only coamoxiclav is the one which doesn't have an quinolone or a macrolide or an aminoglycoside. So the right answer will be the first one. Again, this is more from the pharmacology what you are having here. So just remember that that should be sufficient. Okay, unlikely anything else will appear from this. Just remember quinolone, macrolide, and aminoglycosides. A 30, sorry, a 33 years old male was brought to the emergency department in an ambulance. He gives an history of cough and yellowish color sputum since a couple of days. This morning, he experienced shortness of breath. Hence, he had come to the emergency department, has undergone appendix dumping. Vital parameters shows heart rate on the higher side, tachycardia, tachypnea, hypertension, hypoxic, high-grade fever. IV cannula is secured. Resuscitation is done with 1.5 liters of IV fluid. Recheck blood pressure is on the lower side. What is the next best step in management of this patient? One fluid bolus is given, 1.5 liters they have given. After that, what we'll be doing? Check the IVC. For what are we checking for? Is the IVC compressible or not? So we are checking for the compressibility of the IVC, what we are checking, and we are checking for the size. If the IVC is compressible and it is not distended, you will go ahead and give more fluid. So check for the IVC with an ultrasound is the right answer here. Let us see the other answers. More IV fluids is better to do an IV ultrasound to check the inferior vena cava before you start. Start inotropes. I would have started inotropes if the patient would have received 30 ml per kg. That is 2 liters approximately you would have received. Then I would have think of directly starting on inotropes because more fluid than 2 liters, if you give it, unlikely the patient's blood pressure will improve. Measure CVP. As I said, CVP is it's not a good parameter to check the fluid response or the hemodynamic status after a fluid bolus. Blood transfusion. Why do you want to give a blood transfusion? It's not an hemorrhagic shock. A 79 years old female was brought to the emergency department in an ambulance. She complains of a cough with yellowish color sputum since a week. She gives an history of fatigue and fever since a couple of days, and she is unable to carry out her regular activity. She is a known case of hypertension, Parkinson's, arthritis, diabetes. Her vital parameters are given here, where it shows tachycardia is present, tachycardia is present, tachycardia, tachypnea, high-grade fever, certain amount of hypoxia is present. A diffuse erytheromatous rash, which is non-blanching. I'm already thinking of meningococcal. What is the most likely diagnosis here? Is the patient in shock? I won't call this as shock because the systolic blood pressure is more than 90. Is the patient having meningitis? Nothing is suggestive of meningitis or encephalitis in this patient. Pneumonia? Yes, this patient can be labeled as pneumonia. So we have two options, meningococcal septicemia and pneumonia. Which one we pick up? I would pick up as a meningococcal septicemia because if I use an Q SOFA in this patient where the heart rate is more than 100, yes, definitely more than or equal to 100, yes, it is. Where respiratory rate is equal to more than 22, yes, it is. 2 points are there. That is sufficient for me to label as an sepsis. Along with the sepsis, there is a non-blanching rash present. Yes, meningococcal septicemia is present. So this lung infection can be caused by a meningococcal infection what is having. So meningococcal septicemia is more precise answer what you are having. So considering the rash, considering the history, and considering the vital parameters, meningococcal septicemia is the most appropriate answer. A 50 years old female, unknown case of diabetes, present to the ED with an burning maturation and fever, so urinary tract infection, tachycardia is present. This patient is severely hypertensive. So working diagnosis is urosepsis. Your secured and IV line, IV antibiotics is given 3 liters of fluid, Hartmann's you are given. You have been reviewed by the ITU, you are about to move it. Suddenly, one of your junior doctors sees the mean arterial pressure and says it is 54. Mean arterial pressure, we want it around 65. 65 or more than 65, what is our target? Like how systolic blood pressure of 90, what we are assessing. Rest of the vital parameters are within normal. What is your next step here? What you will be doing? Have we given more than 2 liters here? Yes. If I give more fluid, will it be helpful to improve the blood pressure in this patient? Unlikely. So what I'll be doing, I'll be starting on inotropes for this patient. So which one of the following will say start on inotropes? Start on non-adrenaline infusion is the inotrope. At the same point of time, which inotrope is the preferred for an sepsis or a septic shock? Non-adrenaline is the preferred one. Okay, we always start with a non-adrenaline, then we add up depending on the. Same thing holds good for cardiogenic shock also. Cardiogenic shock also non-adrenaline. Not effective, then you add up dopamine in cardiogenic shock. So non-adrenaline is kind of go-to inotrope whenever you want to start an inotrope. Doses are not required, they'll not be testing in your exam. A 14 years old male kid was brought to the ED by his parents with complaints of fever with rash. They have recently migrated to UK. There is no previous records suggestive of any immunization, so unimmunized. There are no known medical or surgical cases. You are suspecting this patient to be having one of the notifiable diseases. Which one of the following is not a notifiable disease? Malaria, yes. Notifiable. Measles, yes, yes, and yes. EPV is not notifiable disease. The same question appeared in September 2024 diet also. So easy, same repeat recall question had appeared in the last diet also. You diagnose him as in malaria. What is the most appropriate treatment to be given? Malaria, what treatment you will be giving? Artesunate is the treatment of choice here out of given all the drugs. Artesunate is given. Okay, most of the time we end up giving artesunate, though it is a complicated or uncomplicated malaria, we end up giving artesunate. Remember that. Quinine can be given, but it should be added along with the doxycycline. It is given. Not only single monotherapy of quinine is not preferred. Along with doxycycline, yes, you can give it for treatment of malaria. Which one of the following is an indicator of severe sepsis? Is tachycardia an indicator? Tachypnea an indicator? High WBC is an indicator? High temperature indicator? No. Okay. Sorry. Reduced urine output is an indicator or an severe sepsis because this indicates that there is an acute kidney injury. Significantly reduced urine output is suggestive of an acute kidney injury, is an indicator of an severe sepsis. In previous diets, one of your students asked me, tachypnea is present. Tachypnea, can't it be suggestive of an end organ lung injury? No, it is not suggestive of a lung injury because tachypnea can be present because of various reasons. For example, diabetic ketoacidosis can have in tachypnea Kussmaul's respiration. You can see it. So anyone who has a metabolic acidosis will be having high respiratory rate. That doesn't mean that his lung is injured. The lung is working overtime to wash out the carbon dioxide so that the pH is maintained. So just an tachypnea or an tachycardia are not the indicators of a lung or an heart injury. An elderly patient who is a known case of mesothelioma was brought to the emergency department in the ambulance. There is a chest drain in situ for pleural effusion. He complains of feeling unwell since couple of days. On examination, he is tachycardic, slightly hypoxic, and his WBC counts are very high. CRP is also on the very high. I am suspecting of a severe infection. Just an WBC count and the CRP of this range, I need to consider a severe infection. A chest tube in situ, this should be a source for me. Whenever the foreign body is there inside the body, always that I'll consider as a source. What I'll be doing, I want to give antibiotics, yes, but I want to collect the cultures first, both from the pleural aspirate as well as from the venous blood culture. Then I'll be giving the antibiotics. So collect cultures before giving antibiotics. You get an pre-alert regarding a 67 years old male who might be in urosepsis. The patient has been received in the registration bank connected to the cardiac monitor and IV line is secured. There is a history of increased frequency of maturation in dysuria. So urosepsis, we are thinking about tachycardia and tachypnea is present, hypotensive, severely in shock because diastolic blood pressure is not recordable at all. 3 liters of IV fluid you are given. Recheck still systolic is 60. Bedside ultrasound scan shows an IVC of 3.5 non-collapsing. The patient remains hypertensive. What is the next best step management? There are multiple factors for you to consider as an vasopressor in this patient. Okay. Remember, vasopressors and inotropes are interchangeable. There is slight difference between inotropes and vasopressors, but they can be interchanged and commonly used in the medical terms. 3 liters IV fluid, I would have directly gone here without even seeing the ultrasound. Ultrasound, any diameter more than 2 centimeters is distended for me. Non-collapsing is also surgery of distended. I will not give any fluid for this patient because he'll go in fluid overload. For that reason, I'll start him on vasopressors immediately. Again appeared in last September 24 diet. This question. A young female came to the ED tensed. She is requesting to see the doctor as soon as possible. The triad nurse has checked the vital parameters. They are within normal limits. When you go to see her, she is asking about post-exposure prophylaxis of HIV. She has been in a party and had an intercourse with an unknown person. Which one of the following is a high risk source for HIV? So the question basically high risk source. Out of these options, this one is wrong. Splash of semen into the eye, no. Unaware of the history, no. Splash over the unbroken skin, no. Kissing the unknown partner, no. Anal intercourse with sub-Saharan person, yes. Sub-Saharan origin is important word what you need to consider. A 28 years old male came to the emergency department. He gives a history of injury to the right leg while he was forming, which has been contaminated with horse manure. So high risk. This is high risk tetanus prone wound. He has no comorbidities and has not undergone any surgery. The patient has been taken the priming course tetanus, but not the booster. So incomplete course what he has taken. Okay, his vital parameters are within normal limits and systemic examination unremarkable. You have cleaned and dressed the wound. What should be given for this patient? So again, we'll go out to our chart what is present. It is a higher risk wound plus not up to date with the vaccinations to that age. So this person, if you consider this both, then he needs to get both vaccine and immunoglobulin. So this patient gets vaccine and immunoglobulin. A 24 years old male came to the ED. He is a tourist to the UK. He has not taken any vaccination during the childhood. Okay. He feels that he weakens his natural immunity. He complains of fever with a rash since 2 days, which is getting worse. He is a known he has no known comorbidities. You suspect he might have one of the notifiable diseases. Which one of the following is not a notifiable disease? Again, EBV is the similar, different wording. EBV it is. Young male with his recent history traveled to Brazil, presents to the ED with itching all over the body except the face. Vital parameters are stable. Itching and rash is noted over the west spaces as shown in the picture. What is the most likely diagnosis? Picture, you can see lesions over the web spaces and severely itching. Most of us from the subcontinent, it is easy to diagnose. It is the scabies. Okay, treatment for the scabies also be aware of. Treatment is permethrin. Okay, permethrin is the treatment. What you need to remember is the treatment for scabies. A nurse working in the surgical ward came to the ED with an history of needle stick injury. She noticed blood oozing out of the injury. The source is unknown. The nurse has taken 2 doses of hepatitis B vaccine but has not completed the course. The floor in charge nurse has advised her to go to the ED as this is out of hours. The vital parameters are normal, no comorbidities. What you'll be doing? So what will be doing? She's partially vaccinated. The source is not known. Whether it is a significant exposure? Yes, it is a significant exposure because it is a needle what she has had it and it has pierced the skin. So 1 dose of Hep vaccine and finish the course, what we'll be doing. Because she's partially vaccinated, so give one. It is unknown, so we are not giving immunoglobulins. So give 1 dose of hepatitis B vaccine and refer to the occupational health so that the whole course is completed. 1 dose of hepatitis vaccine followed by second dose 1 month later, no. We just ask them to follow up with the occupational. They will decide when to be given. Finish the course of, no, 1 dose has to be given in the emergency department. Reassure and do not, this is not the right phrase at all. Test, no, we do not test. You immediately test, it will never come positive. A 76 years old female present to the ED department with complaints of fatigue and dizziness. She is a known case of breast cancer on immunosuppression therapy. On questioning about her fever, she said she had an urinary tract infection, which is which is on oral antibiotics for the same for last 3 days. Her vital parameters are given like this, and she's febrile. What is the next step in management of this patient? Next step, I want to give IV antibiotics, especially the IV piptas, what I want to give in this patient. Before this, I want to collect the cultures. So I'll select and send and full blood count to see the neutrophilic. So I'll select an option which has a full blood count, culture, and antibiotics. Out of these options, wait for the results before starting antibiotics. No. IV fluids, blood culture, urine, IV antibiotics, full blood count, and yes, this is the right answer because we're not waiting to start the IV antibiotics. We start it Then we wait for the reports. A 67 years old male was brought to the ED in an ambulance. He complains of fever with a cough. So fever with a cough for last 3 to 4 days. On examination, these are the vital parameters what they are given. According to the UK sepsis guidelines, you are diagnosed with severe sepsis. Blood samples have been collected. Investigation and admission, IV fluids and oxygen has been started. What is the most appropriate next step in management of this patient? Is this patient is in shock or not? No, the patient is not in shock. Not in shock, we give antibiotics. Before being antibiotics, cultures should be collected. So blood samples have been collected. So I can directly go ahead and give IV antibiotics. The same patient, if I change it, the blood pressure to 80/40, then I will go ahead and give IV fluids, which is not mentioned in the options. I would have given IV fluids for this patient if the blood pressure was on the lower side. A 28 years old female has fallen from an horse and sustained injury to the leg. She has no known comorbidities on examination of vital parameters are within normal limits. She has an external small puncture on X-ray shows and tibial fracture. Small puncture on tibial fracture. Previous chapters, remember it is a compound fracture. Compound fracture is nothing but open fracture. Open fracture always give antibiotics. She gives an history of taking tetanus vaccine when she was in school and in her childhood. That means last dose is given at 14 years. She is 28 years. So the last dose was given 14 years back. So it is more than 10 years the last dose what she had. So more than 10 dose what she had, along with it, this a puncture wound with a tibial fracture is a compound fracture, becomes an tetanus prone wound. So tetanus vaccine with IV antibiotics needs to be given for this patient. Okay, so tetanus vaccine is required along with IV antibiotics. What is required for this patient? Do not forget. We need to think about IV antibiotics also. That's why we are giving an IV antibiotics also. This is only tetanus prone wound here. It is not an high risk. So immunoglobulins need not be given here. Only vaccine is required plus IV antibiotics is required. Immunoglobulins not required because it is only a tetanus prone wound. It is not an it is only tetanus prone wound. It is not an high risk tetanus prone wound. For that reason, we are choosing only vaccine plus antibiotics for this patient. Antibiotics because it is an open fracture. Tetanus vaccine because it is a tetanus prone wound and the last dose was taken more than 10 years back. A 25 years old police officer present to the emergency department with a week-long history of myalgia, fever, nausea, vomiting while cleaning house of dead animals. Whenever the dead animals comes, you need to think of leptospirosis. Okay, think of leptospirosis. Dead animals, especially cleaning the dead animals, feces or urine of the dead animals. Think of leptospirosis infection. It has been tested in the last dead also. I'll be coming to that question. Then these are the vital parameters. There is an icterus, bilateral conjunctivitis, high temperature, hepatosplenomegaly. These are all complications which can be seen in leptospira. It is also known as Wheels disease. Remember this point. They're just asking how do you confirm? You confirm usually by doing an serology. Serology can be done from urine sample, blood sample, or CSF also can be done. Preferred one is urine sample. Serology, what do you need to do to confirm the diagnosis? What are the options is the serology, what do you need to do with it? A 34 years old female came to the ED with complaints of fever and headache. Since a few days, she met her GP for the same and was started on oral antibiotics. She has completed the course of oral antibiotic and continue to have headache and fever. Now it's associated with neck stiffness. Okay, we are thinking of a meningitis, fever, headache, neck stiffness. I'm thinking of meningitis in this patient. On exam, no known comorbidities. On examination, there is some amount of tachycardia, tachypnea is present, neck stiffness is present. Next best step in the management. What I want to do, I want to give this patient antibiotics and I want to give IV dexa. That is dexamethasone. Which one of the following? IV antibiotics is not given, so I'm directly choosing an IV dexamethasone. IV dexamethasone should be given along with the antibiotics or just before the antibiotics. It is known to reduce the morbidity and mortality. That's the importance of giving that's the importance of giving dexamethasone. 8 months old baby was brought to the MS department in an ambulance and the baby had an involuntary movements of the upper limb. So involuntary movements of the upper limb the baby had. Later, all four limbs were involved. So it was an just the upper limb, what we left upper limb, it was involved. The focal seizures have converted into generalized seizures. Currently, the patient seizures have subsided. The baby is not moving the left upper limb and the lower limb. On examination, tachycardia, tachypnea, blood pressure borderline fine. CRP is on very much on the higher side. What's the most likely diagnosis for this patient? So what are we suspecting? Though I have marked here, what are we suspecting? Why are we suspecting? So if you consider this as a brain parenchyma, this as an abscess, it becomes an space occupying lesion. This space occupying lesion can have focal neurological deficit. This is the focal neurological deficit what you are having. Along with it, they can present within seizures. Yes, they are presented within seizures. It was in focal, which has converted into an generalized. So this is a clear-cut case of cerebral abscess. Febrile conversions will not have a focal seizure. Okay, remember that febrile conversion will not have a focal seizures and will not have a focal neurological deficit. Hypoglycemia can present, but usually the seizures happens if it is more, no, sorry, less than 2.5, not within sugar levels of 3.5. Stroke. Stroke patients, seizures, if it is present, Rogers criteria, if you remember it, 8 months, unlikely to be stroke. But still, if you consider Rogers criteria, stroke itself, seizures itself has -1. So unlikely it is in seizure. Primary seizures, yes, you can consider it, but there is a focal neurological deficit. There is a high CRP. It's not suggestive of a primary seizure, or you need to think of something else. One of you have mentioned as an LP. Why do you want to do an LP in the patient? As I told you, do not wait for an LP to give an steroid or an antibiotics. So you're not waiting to do an LP. LP takes hours together. If you wait for that point of time, the mortality and the morbidity will drastically increase. So do not do an LP. LP is not the priority. Always remember that LP is not a priority. A 29 years old male who is a known case of IV drug abuser present to the emergency department with complaints of headache and dizziness since last few days. In emergency department, the patient has an generalized tonic-clonic seizures lasting for a few minutes. On examination, tachycardia, blood pressure is fine, tachypnea is present, hypoxic, high temperature, and GCS is on the lower side with an unequal pupil. What is the most likely diagnosis? As I told you, whenever there is an IV drug abuser, you want to think of a central infection, a subdural a subdural empyema or epidural abscess. You need to think of epidural abscess or subdural empyema. What do you need to think of? So IV drug abusers always pick an subdural empyema or an abscess. A 43 years old presents with an history of fresh hematemesis. He has and had 3 to 4 episodes and consists of one full mug of fresh blood is there. He's a known case of alcohol dependent with documented alcoholic sclerosis and known to hepatology. Observations just shows there is some amount of tachypnea and tachycardia. Blood pressure is on the lower side. 85 is the weight what they are given. These are the lab values what they are given. Which one of the following initial intravenous fluid is most appropriate? Which one of the following what you need to give? Remember that we have two fluids. RL or Hartmann's means one and the same. Do I give this in this patient? No, I do not give in this patient because this patient has a liver disorder. So that is contraindicated. If this is not recommended, the next one comes is normal saline. So I'll be choosing a normal saline here. The fourth one is a normal saline. We usually give in boluses of 500 to 1000 ml. We do not give as big bolus as 20 ml per kg is not recommended. 500 to 1000 ml is recommended. 20 ml per kg, it goes is 85 kg. So 85 into 20, if you multiply, it is almost, if I'm not wrong, it almost more than 1.6 liters it will be. It is a large amount which we do not give it. The nurse asks you to review an 40 years old patient. The news 2 score is 9, who meets the criteria for sepsis, and she has already obtained an IV access. An appropriate blood test, including the blood culture, has been collected. Okay, there is tachycardia. This is on the lower side. Blood pressure, very important. Shock. According to the line guidelines, what is the most appropriate treatment? Here they are asking. Commence oxygen administration or insert a catheter to monitor the urine output. Start on IV antibiotics. Consider vasopressor support. They are not given fluids. Give the patient fluids. So the right answer here is the fluids. One question many people asked that they got confused. Some picked up and to monitor catheter they have picked up. I don't know for what reasons. Few picked up giving IV antibiotics. This patient is unstable, so you're not going for IV antibiotics here, and you need to give fluids. Few were worried that 2 liters of bolus of crystal they have given. It's fine. It's okay. You can give it someone who is a 40 years old. You can give it. The recommendation is, I do agree that it is 100, I'm sorry, 500 to 1000 ml, what is recommended, doesn't mean that you cannot give 2 liters of crystalloids. You can still administer it. This was the right answer there. This is time sensitive. The patient is in shock. So you need to treat the shock, which comes in C, circulation. Shock needs to be treated as soon as possible. A 25 years old police officer presents to the ED with a week-long history of myalgia, fever, nausea, vomiting after cleaning an house containing dead animals. Cleaning a house containing dead animals, always think of an leptospirosis infection. Okay, it's already an leptospirosis infection. Upon examination, there is some amount of tachycardia and this and febrile. Jaundice is present, significant icterus is present, likely diagnosis, leptospira. So this was again last diet. This question was also last diet. This question was also last diet. A 7 years old was brought to the ED by his mother after being bitten by a dog, neighbor's dog, while he was playing. No other injuries were noted. On examination, there is a puncture wound on the leg, but no blood drawn. So no blood is drawn. That is important. Do we give antibiotics? No, we don't give. The boy is complaining of pain. Although paracetamol has been administered, he continues to experience pain. What is the most appropriate next step in the management of the plan? So he's continuing to have the pain. So I would like to give a analgesia for this patient. Ideally, I would give an analgesia and no antibiotics. So I want to search an option which has no antibiotics and analgesia. Okay. Most of them got selected option 2, which is not correct. Okay. Out of this, there is no option which says analgesia plus antibiotic. No antibiotic, no wrong. Codeine and oral antibiotics. I'll come back to this. This is also wrong because we do not want to give antibiotics. Oral antibiotics, we do not want to give antibiotics. So no antibiotics is the right one. Why didn't I choose an analgesia plus antibiotics? What I want to give, because this patient is experiencing pain. Mainly because codeine. Codeine is contraindicated in anyone less than 12 years age. It is not recommended. If you remember the anesthesia class, I said codeine is contraindicated, give oral morphine. Why it is contraindicated? Anyone remembers? Because the metabolism is it doesn't get metabolized well in the pediatric age group. It remains in the body for a very long time, causing more side effects. So no codeine. Okay, that was the trick. So basically, if you are remembering the anesthesia class and remember this infectious class, then you can easily answer it. It's the combination of the two things what they are asked for. So again, it's a dog bite, skin is broken, not given, so we're not giving the antibiotics. Of 17 years old male has fallen from a horse, sustaining an injury to his right leg, which is contaminated with soil. He denies any injuries and states that he has received all vaccinations as advised by his GP. What is the tetanus prophylaxis advice what you're giving? 17 years, he's taken all the vaccines. So when is the last dose we give it? 14 years. Is it less than 10 years the last dose? Yes. So less than 10 years doesn't matter, even though if it is a high risk, you do not give anything. Again, what is required? No treatment is necessary is the right answer here. So first one is the right option here. Again, it's not in booster dose with 1 arm and tetanus prophylaxis. No, because he's completely vaccinated, up to date with the vaccination, and the last dose is within 10 years. Yes, he's only 17 years old, not for 17 years old, not some 38 or 40 years old to think of as something else. So again, this was the right answer. Again, this is covered in the class. It's there in the algorithm and which has appeared in the last diet. A 32 years old woman recently returned from Bangladesh, present to the emergency department with fever and chills over the last few days. She is 8 weeks pregnant with no known comorbidities. You strongly suspect an malaria, and she is pregnant. Which of the statements is correct regarding malaria? A negative thick and thin blood smears exclude the diagnosis of malaria. As I said, if you collect the blood sample during the chills time, then only parasite can be isolated. Otherwise, parasite might not be isolated. Sometimes in multiple blood investigations, they will be sending for thick and thin smear to diagnose in malaria. So multiple blood samples might have been sent. It doesn't rule out. A palpable spleen makes another diagnosis more likely. No, unlikely. Splenomegaly is seen in malaria. Blood for thick and thin smear should be collected in an heparinized bottle. No, it is not in a heparinized bottle. It is a direct blood which is put it on the slide and it is smeared. Pregnancy can affect the diagnostic accuracy of thick and thin smear. Yes, this is the right answer. This was the difficult one, which was not covered in the class, to be frank. This is a difficult one. What happens in pregnancy here is there is increase in intravascular volume. Increase in intravascular volume. Due to increase in intravascular volume, there will be dilution. Because of dilution, the parasite what you are drawing in the blood will reduced. So the efficacy or the accuracy of thick and thin smear reduces. Okay, if in a normal person, the sensitivity and specificity is around 90%, it will come down to around 75% in a pregnant woman. So this is the right answer. She's at low risk of acquiring malaria in Bangladesh as she is a tourist. No, it doesn't hold good in the manner. It is sorry, it is transmitted by a mosquito. You go to an endemic areas and you get bitten by a mosquito. That is enough to label it, or that is enough for you to get a malaria. A 60 years old female unknown case of CKD on dialysis present to the emergency department with complaints of fever and rigors since morning. She has a perm cat in situ for dialysis. Observations are shown here. Fever is present. What is the next best step? It was a similar question. One question was added. Send tip of the perm cat for culture. That was the one option there. Do not remove the perm cat for culture. Nowhere here says that there is some oozing or from the side of the perm cat there is pus which is coming out. Redness of the skin is there. Suggest you have the whole perm cat, you need to remove it on the immediate basis. So just collect the blood samples from the perm cat. If you're strongly suspecting later on, make sure there is some other way to do a dialysis before you remove the perm cat. Drastic steps shouldn't be taken by removing the perm cat. The nephrologist will be unhappy with you. A 63 years old male was brought to the emergency department in an ambulance. He gives an history of cough and yellowish color sputum since couple of days. His observations are as follows: where the blood pressure in shock. So IV line is secured. Initial resuscitation of 2.5 liters IV bolus. Recheck blood pressure still in shock. What is the next best step in management? 2.5. So anything more than 2 liters, I will start on inotropes. So directly I'll go and start on inotropes. It was very much similar to the previous questions what we had discussed, which has again appeared. So IV fluids, again, giving IV fluids unlikely to improve. We might give it eventually. Doesn't mean you shouldn't be giving. But to improve the blood pressure here at this point of time, inotropes needs to be given. Measure CVP. CVP is not easy to measure. You need to have in central line, and it doesn't very much respond to the hemodynamic response to the fluid resuscitation. Antibiotics, unstable, think of fluid, increase the blood pressure. Antibiotics comes later. Blood transfusion, absolutely wrong. Anyone had a question of... So that ends here. Anyone has any questions, you can ask me.